That's your walkout song now.
All right. Good morning, everybody. Everybody can hear me, right? We're good to go?
Yeah.
Sounds good. All right. Hope you guys had a really good. Hope you guys had a really good week. I hope classes went well. If you guys have any questions, I'm also catching up with emails right now. Sorry I haven't responded to some of you all, but I'm trying to catch up all the emails I've gotten at once. And I was trying to like work on the notes and like the Fridays quiz questions as well. So don't worry, I'm gonna get back to your emails this weekend for sure. So after this these sessions today and then the TA quiz at 2, I'll make sure to get back to your emails today, tomorrow, or at least Sunday for sure. So I'll make sure to get back to those. But if you have any pertinent questions right now, feel free to let me know. And if not, then we'll just get started. All right. All right, let me just share my screen and then we'll go. Okay. Where is this? Okay, there we go. All right, can everybody see my screen?
Yeah.
Okay, perfect. All right, so we're gonna start with the anterior abdominal wall, and then we'll go into the posterior abdominal wall, and then that would be the last lecture that Dr. Muffley gives for this exam block. So the next lectures after that are gonna be Dr. Weranowska, and then as well as Dr. Lopez. So the lectures are gonna look a little bit different, but I mean it's just gonna be same anatomy material, it just won't be like looking the same as like Dr. Muffley's slides. So we'll go through those, and then I'll make sure to hone in on what's I think is more important on those slides in regards to like how the professors teach. But for now, we're going to go over the last 2 lectures for the block for Dr. Muffley, which would be the anterior abdominal wall, and then we'll go to the posterior abdominal wall next. All right. Let's see. Hold on. Okay, objectives, I'm going to skip that for now. Okay, so for the surface anatomy, basically, I just highlighted a few things that are going to be, I guess, on this slide that we don't talk about too much. We talk about the external oblique, the rectus abdominis. We talk about the serratus anterior so much already. Does anybody remember what the innervation of the serratus anterior is?
Long thoracic nerve.
Yeah, the long thoracic nerve. Yeah. So I just throw in questions sometimes in there just to see if you guys are remembering the old material. But yeah, long thoracic nerve. So external oblique and the rectus abdominis, we'll be talking about those a lot more. But I definitely started the linea semilunaris as well as the linea alba. Just because they kind of sound the same, but you just need to note that the linea alba is just this straight line down the midline that's going to give you like those obviously the divisions between the right and left sides of the rectus abdominis. And then the linea semilunaris is basically going to be on the outsides of it, the lateral sides right here, where the aponeuroses of like the external and internal obliques come to the rectus sheath. But we'll talk about that a lot more. I put the image right here. This would be like the linea alba coming straight down, right? All right, so for abdominal regions, so again, I would cross this image out. You don't need to worry about like the 9 quadrants. He said in class, he was like, oh, like, don't worry about that. He's not going to test on those, so don't even worry about those. The ones that you really need to worry about is going to be these 4 quadrants on the right-hand side, which is going to be the right upper, the left upper, the right lower, and the left lower. So we'll show that in the next upcoming slides. Okay, so basically he put all the organs, yeah, or all the organs in their own like category in regards to like the right upper quadrant and like left upper quadrant. But on the next upcoming slides, I kind of divided it in what I thought would be high yield. Of course, you can test on anything that's in this on these columns or like in these like little boxes. You can test on anything, but I pointed out the things that I believe would be the highest of yield because everything else kind of just makes sense. So like when I skip into the slides, you'll see what I'm talking about. But I divided it into obviously the 4 different categories, and I highlighted what I believe would be the highest of yield. So like on this slide, for example, oh, wait, can you guys hear me or no?
Yeah, we hear it.
Yeah.
Okay. Seems like the sound is working for Brendan. All right. So the right upper quadrant. So basically, this is the same exact thing that was in the column, right, or in the like the box thing. So for the right upper quadrant, I just highlighted or put a star next to the things that I believed were the highest of yield, right? So for example, like the liver and the gallbladder, those are like for sure things that you have to know are in the right upper quadrant. I inputted an image right here as well just to help you, right? So I drew these lines right here just to show you, okay, right upper quadrant, left upper quadrant, right lower, left lower. And just to give you a general idea of where these organs are, because I saw in the last slide the organs weren't there, so I wanted to input an image to show you where these organs were. So you can see that majority of the liver is in the right upper quadrant, which I believe is the highest of yield, because when you associate the liver, most people associate it with the right upper quadrant because such a large portion of it is there. Right, gallbladder is attached to the liver, so that's super high yield to know in the right upper quadrant. Stomach, not so much. It's more so associated with the left, but you have the pylorus, which is this part right here, going inside of the duodenum, right? So that's also associated with the right upper quadrant. The pancreas, and then I didn't highlight these because they're just gonna make more sense when we talk about it later on, because I inputted this image right here. You see how high the kidneys are? Like the kidneys are like so freaking high that like they're each associated with their own quadrant, right? So you know that you have 2 kidneys, so you know one is gonna be in the right upper quadrant and you know one's gonna be in the left, right? That's a given. So like some of the things like I didn't like highlight because I believe that like, oh, if we just think about it, we should be able to figure out which quadrant they're in, as well as like the suprarenal gland. Like those are the adrenal glands that are attached to the kidneys. They're on top of it, so they have to be in the right upper quadrant as well. You see what I'm saying? So it's not like you don't have to like force yourself to remember all of them, but I did put the highest of yields, obviously, that I believe that he would definitely test on. And again, the flow basically. The flow of bowel, basically, in order just to help you a little bit out, just to understand why these things are associated with the quadrants, like the ascending and transverse. What happens is that when the bowel comes through, like the small intestines first, which is like this ginormous blob, it goes into this ascending colon, right? Once it goes into the ascending colon, it goes up into the and then into the transverse colon, then down the descending colon, out down the sigmoid and out the rectum, right? So that's the flow of bowel, and if you just understand how the flow of bowel goes, then you'll be able to understand which specific things are in their quadrants as well. So I highlighted those for the right upper quadrant. For the right lower quadrant, again, I highlighted the cecum, the vermiform appendix, and most of the ileum, as well as the ascending colon. The cecum and vermiform appendix are by far the highest of yields in regards to the right lower quadrant, just because they're like super unique to all in regards to all the quadrants. Obviously, your vermiform appendix is only on the right side, bottom right, and your cecum, which is going to be the attachment between the small intestines to the large intestines, is only on the right side. I also highlighted these, most of the ileum as well as the ascending colon, because if you understand the flow of bowel, you'll understand that the inferior portion of this ascending colon is also associated with the right lower quadrant. But I didn't start anything else because, I mean, if you understand like the right ovary, the right uterine tube, the ureter, the spermatic cord, like you know those are associated with the genital region, you know it's pretty low. And then if they say right, it's obviously on the right side. So I didn't highlight these. So I mean, you could memorize them, but I definitely feel like they're on the lower of yield ends. These 4 are definitely going to be on the higher of yield ends. So I wanted to make it like a little bit more digestible, just because like it looks like a ginormous chart, but in reality, like if you just circle the highest of yield stuff and then use like, I guess like think about the other ones, they'll make a little bit more sense. Left upper quadrant, spleen and stomach for sure, definitely the highest of yields when it comes to left upper quadrant. Your spleen is only on your left upper quadrant. You only have 1 spleen, and the majority of your stomach is on the left side, right? Top left side. I also inputted these as well. But again, if you understand the movement of the bowel and you understand where the kidneys are, you should be able to put together where these are located, right? That's why I put a picture of the kidneys here as well. And then the last one, which would be the left lower quadrant. I would think the most significant thing in the left lower quadrant is for sure the sigmoid colon. Also the inferior part of the descending colon, but again, if you know that the bowel movement goes from ascending to transverse and then to descending, you should be able to figure out that the lower part of the descending colon is part of the left lower quadrant. But yeah, sigmoid colon for sure. That's going to be like this little S right here going into the rectum. That's the highest of yield. And other than that, like if you look at this, like left ovary, left uterine tube, like left ureter, like left, like those are things that like, you know, like yes, they're associated with the genital region. And yes, we should be able to like pick it out because you're saying left with it. But in reality, for the left lower quadrant, all you need to know is two things. If you know what I mean? Everything else is just a given, right? Okay, so here comes one of these questions. So which of these are in the right lower quadrant, right? So is it the liver, the transverse colon, the cecum, the stomach, or the sigmoid colon? Right. Testing your knowledge immediately. I'll give you one more second. Right lower, so. All right. And yeah, so you guys were pretty quick. Really good job. It is going to be the cecum, right? Can anybody name me one more like really high yield organ, like or structure that's in the right lower quadrant? Super high yield. Yeah, the appendix. Yeah, the vermiform appendix. So I would definitely keep those on the highest of your yields in regards to the right lower quadrant. For sure, the vermiform appendix and the cecum as well, right? So the sigmoid colon is actually on the left lower quadrant, right? So it's on the opposite side. So don't get those two mixed up, right? The liver we know is associated with the top right. This is the right upper quadrant. Transverse colon gets both of the tops, so you know, like the right side of it, and then the left side gets the left side, obviously. Stomach is mostly on the top left, and we talked about the sigmoid. So yes, really good job with those. Okay, so for the layers of the anterolateral abdominal wall, we're going to go through these. These are basically going to be from superficial to deep, right? So he lists them right here in their order. So this is going to be from superficial, all the way to deep. So on the next upcoming slides, I put a couple of images that I thought would really help us in regards to understanding what's going on in regards to the anterolateral wall of the abdominal wall and what happens when it goes down to the spermatic cord, right? All right, let's see. Okay, so I put this image. I just feel like it was really clear in regards to what's going down, like in the abdominal wall. So basically, like we said, the top layer is obviously the skin, right? Right under that, you have this layer that's called Camper's fascia. And it's like a super thin layer. It's just basically just of like fat, basically. Right under that, it's going to be the Scarpa's fascia. And then you have, these are just going to be the deep investing fascia, not too high yield. Just know that these deep investing fascia are surrounding each of the muscles, right? So, and then I have the muscles located right here, which would be external oblique, internal oblique, transverse abdominis, and then back to the peritoneum, but transversalis fascia and back to the peritoneum. So on the next slide, I kind of like highlighted the things that I believe are going to be most important in regards to going from superficial to deep, right? So I think this picture is pretty clear on what is going to be located on the anterior abdominal wall, going from the superficial side to the deep side, right? Oh yeah, so I guess I did it in a question. Okay, so which of these are ordered correctly from superficial to deep, right? So I'll give you a little time to look at it, but is it going to be A or B in regards to the order? So going from the superficial to deep. Don't worry, we'll clear this up if obviously we went through it really quickly, but this is just to get your mind flowing in regards to that. Yeah, so between A and B, I kind of switched the two like things that people get, I feel like mixed up the easiest just because they kind of sound the same, which is why I switched up the transversalis fascia and then the transversus abdominis. But we'll obviously see the correct answer on the next slide. But I just wanted to make sure that we got those right in order because obviously it's extremely important when we start talking about the arcuate lines. So I definitely mixed those up on these two answer choices just to make that a little bit clear. But yeah, so I'll show you on the next slide. It's actually going to be B. So it's actually going to be from skin to Camper's fascia. So I'll show you on the last one over here. Like we said, we know skin to Camper's fascia, then to Scarpa's fascia, right? We got that. After that, it's just going to be the muscles coming straight down, the external, internal, and transverse abdominis, right? So you're not breaking the muscles apart, basically. The only thing that's separating these muscles are going to be this deep investing fascia, but he's not going to test you on that. Like, he won't say which one of these going from superficial to deep. He's not going to say deep investing fascia of the external oblique, deep investing fascia of the internal oblique. You know what I mean? Like, he just cares about the muscles. So if you really wanted to know the order, it would just be from skin to Camper's, then to Scarpa's. The three muscles under that, which would be external, internal, and transverse abdominis. Then you have the transversalis fascia and then the parietal-peritoneum, right? So make sure you keep those muscles in order. They're not breaking up. Only when it comes in regards to the arcuate line, that's when we'll talk about that when things change a little bit. So that's for now. All right. So again, we have our superficial fascia. Whenever he says superficial fascia, it just means like the Camper's fascia as well as the Scarpa's fascia. Right, so sometimes in the PowerPoint he says like, oh, the membranous superficial fascia. He's talking about like Scarpa's fascia, right? So like those are just going to be used interchangeably. So excuse me. So the superficial fatty area is going to be the Camper's fascia. That's just going to contain your superficial veins, right? So anything that's like just draining like superficially, it's honestly very, very hard to see in like cadaver labs. Like you probably like incised like through the cadaver and like you just probably passed it without even knowing. Like it's really, really small. But the membranous, basically, that's Scarpa's. That's actually going to be something that you can actually surgically suture. So again, the differences between Camper's and Scarpa's is that you can actually surgically suture back the Scarpa's fascia, but you can't surgically suture back the Camper's fascia because it's just fat, right? So you're not going to like suture together fat, right? So that's one of the main differences. And then the Scarpa's fascia also gives the rise to the fundiform ligament of the penis, right? So when we start going into the Scarpa's fascia, there's going to be a lot of things that the Scarpa's fascia gives rise to. And I'm going to try and keep that in order for you all, okay? So again, the first thing that the Scarpa's fascia is going to give rise to is the fundiform ligament of the penis, right? So I would note that for sure. This is just saying that like you have a lot of anastomoses, right? So paraumbilical veins, anastomoses into the superficial epigastric veins. This is just saying that like you have a lot of anastomoses within the anterior abdominal wall. We'll talk about this at the end of the lecture as well, or the end of the next lecture, I forgot, but we'll talk about that a little bit more. But this is just saying that you have a bunch of anastomoses, and the only thing I would probably just know is that the paraumbilical veins normally drain into the portal vein, right? So they normally drain into the portal vein, but obviously they can anastomoses with these veins as well. So basically what they said in the next slide is that portal hypertension can lead to this thing called caput medusa, which is basically, like he said, like it kind of looks like those like hairs like this, like coming outwards like that. Basically what happens is that if you have portal hypertension, the same thing can happen in the inferior vena cava. So think about it like you have your major venous like drainage, like in regards to like your lower like body, it's going to be like the portal vein or as well as the inferior vena cava, right? Those are very large veins, right? They flow like a lot of blood, a lot of venous blood. And if you think about it, if you have hypertension, for example, in the portal vein or in the inferior vena cava, what's going to happen is that, remember, that blood is always going to find a way back to the heart, right? But it's since the portal vein, let's say, for example, is like, let's just say clogged or something because of like portal hypertension, the veins, the venous blood from that portal vein has to go somewhere else. So it's going to go in all the other veins, right, that go back into the heart. What's bad about that is those veins aren't used to carrying so much blood like the portal vein or the inferior vena cava, which can then lead to this thing called caput medusa. It can lead to varicose veins, which is basically just going to be like veins like inflaming. And if they get too big, they can burst. Like this, it's just bad things, obviously, right? So that's what happens if you have portal hypertension. It can lead to caput medusa. Medusa, it can lead to like varicose veins. It can lead to lots of things. So that's what he's saying on this slide. So same thing in this picture. Okay, so for the membranous, so right here he says like membranous layer of superficial fascia. So that's just basically saying Scarpa's fascia, right? It's just like a long way to say Scarpa's fascia. So again, like right here it says the same thing. The membranous layer of the superficial fascia, remember again, he's just saying Scarpa's fascia, is continuous with the tunica dartos, right, of the scrotum and the superficial penile fascia, right? So now we're like, okay, so the Scarpa's fascia is giving rise to a few things, right? We talked about the tunica dartos of the scrotum as well as the superficial penile fascia. So that's going to be located right here. just superficially on the penis right there, as well as the tunica dartos, which would be surrounding the scrotum, right? So on this slide, so Scarpa's fascia turn into all of the following except, so fundiform ligament of the penis, superficial penile fascia, tunica dartos of the scrotum, or none of the above. Scarpa's fascia, also known as the membranous layer of the superficial fascia. Okay. All of the following except, right? Give you one more second. All right. So yes, it is going to be D, none of the above, right? So now you have a list of all the things that Scarpa's fascia is going to turn into, right? Which is going to be the fundiform ligament of the penis, which is basically, it's just like this ligament that surrounds the entire like width of the penis. It's kind of like a circle thing that attaches to the abdominal wall. That's part of Scarpa's fascia. The superficial penile fascia, which is just superficial, like on top of the penis, and then you have the tunica dartos of the scrotum, right? So those three things are just gonna be coming from Scarpa's fascia, right? He actually didn't put, I was gonna put a picture. I just thought it was too much, but I was gonna put a picture of the fundiform ligament of the penis. But basically, if you imagine right here, here's the penis right here, and it would basically be this ligament coming from here, wrapping around the entire penis right there, and like kind of like pulling it upwards. That's what the fundiform ligament is. It's not shown in this image, but that's what it would be. That's where it would be exactly. Yeah, I was gonna post a picture of it, but I was like, it's too much. That's why I just like put it here. I just said that's what's gonna look like, just like this. Okay. Oh, again, yeah. So here's a little summary slide. So Scarpa's fascia again, fundiform ligament of the penis, the superficial penile fascia, and then the tunica dartos of the scrotum, right? So again, you can see like right here, Scarpa's fascia. I like put like the star right here, turning into the superficial penile fascia, right? And as well as the tunica dartos of the scrotum, right? You can't see the fundiform ligament here as well, but just picture it coming from here, wrapping around the entire base of the penis right there, and kind of like pulling it upwards. That's what it does. So that's the fundiform ligament of the penis, right? So all he said here is that there's just a potential space between Scarpa's and external oblique. Nothing too high yield. Again, remember, again, when he says membranous layer of superficial fascia, it's the same thing as saying Scarpa's fascia. All he's saying is that there's a potential space. Nothing testable here, to be honest, yeah. Just that there's a space between the external.
What would you be in that space? Like, why did he point out that there's a space there if it's not testable and we're not going to do anything there? Like, I guess I missed that.
Yeah, so he just wanted to say there's a potential space, maybe for extra room of the inguinal canal or the spermatic cord, but he just said that there was just a potential space, and he said it last year, and then it honestly is not high yield. He just wanted to say that there was extra space. I don't know. Sometimes he throws things in there in slides that he just wants you to know, but definitely not going to be testable material. So I wouldn't worry too much about this. I just wrote down, if you wanted to, it would just be a potential space between Scarpa's and external oblique, but that's about it in regards to this slide.
Thank you.
Yeah, of course. Okay, so the deep inguinal rings, so we'll talk about these, excuse me. We'll talk about these more as we go throughout the lecture, but basically you're going to have like a deep inguinal ring and then like a superficial inguinal ring, yeah. So basically those are going to go down this inguinal canal, basically, which comes from this anterior superior iliac spine all the way to the pubis, right? So basically, the deep inguinal ring would be closer to the ASIS, right? Because it's going to be like deeper, and then your superficial ring will be more closer to the pubis, where it's going down to the scrotum, right? In regards to that, that's going to be the deep inguinal ring, and we'll talk about this a lot more, but it's going to be very important in regards to what's going to be made by the transversalis fascia, right? That the deep inguinal ring is going to be made by the transversalis fascia. We'll talk about that a lot more when we come throughout the lecture, but for sure, we'll definitely decipher these rings. Okay, so he basically put all of these images here. On the next slide, I just enlarged them and put them like separated because I felt like they were just too small and clumped up. But on the next slide, I just put the ligaments on this one slide, which would be the inguinal ligament and the lacunal ligament. I also inputted an image right here just to give you like obviously a picture perfect image of what the inguinal ligament looks like. It's this structure right here, going from the ASIS, which is the anterior superior iliac spine, all the way to the pubic tubercle, right? If you match that right here, it's this entire thing, right? That would be the inguinal ligament, right, coming down. And again, this is going to be the inguinal ligament on the interior side, right? This is just the inside, like this is like the inside of this flap. Like if you look on the inside of it, that's going to be the inguinal ligament, right? And again, here are the attachments right there. The lacuna ligament is basically what it is it just attaches like the inguinal ligament to the pubis on another location, basically. So you can see this lacuna ligament right here, helping to attach the inguinal ligament onto the pubis in this area right here, right? So that's what the lacuna ligament is. It's kind of just like a little triangle structure. Very hard to see, but you can see in this triangle, that would be the lacuna ligament, right? So I put that there. Over here, we have the conjoint tendon, the superficial inguinal ring, and then the crucis. So basically, the conjoint tendon, we'll talk about this later on throughout the slide, but it's basically going to be made up of the internal oblique as well as the transverse abdominis muscle, right? So the transverse abdominis muscle and the internal oblique, which we'll hone in on that like later on throughout the lecture, is going to make this little conjoint tendon. Right, so this conjoint tendon, which is like located right here, it's kind of like it's like a triangle that's like attached to the midline. Basically, that's the conjoint tendon. It's gonna be attaching here and then attaching to the midline. The superficial inguinal ring, as you can see, it's more towards the genital area, right? It's closer to the genital area. That would be the superficial inguinal ring. And then he also talked about the superior and inferior crucis. Remember when they say like medial and lateral? I know it's like. It's the same thing when they're talking about that in regards to the inguinal ring. Like the superior crucis is the same thing as the medial crucis, and the inferior crucis is the same thing as the lateral crucis. Because some books will call it medial crucis and lateral crucis, and some would say superior and inferior. But just note that those are going to be used interchangeably in regards to that. So this is superior, and this would be the inferior crucis, right? Also known as medial and lateral. Okay, so we're going to talk about the muscles of the abdominal cavity, and then I'm going to break them up into like what I feel like is going to be the highest of yield in regards to that. So for example, we have the external oblique, right? So this is going to be the cartoon image, right? And this is going to be the cadaveric image of the external oblique, right? It actually starts up pretty high up, right? So ribs 6 through 12. It goes all the way to the linea alba, the pubic tubercle, and the anterior half of the iliac crest. Forms the free margin inguinal ligament, but basically, the external oblique is going to form the external spermatic fascia, right? So that's important to know. Like I would definitely note that the external oblique is going to form the external spermatic fascia. And in the next slide, I'll show you what that means, right? Because I want you to like understand like what that like obviously means, because it kind of seems weird to see that like an abdominal muscle is going to be partaking in the like the scrotum, for example, right? But it does. I'll show you in this next slide. So external oblique going to form the external spermatic fascia, right? Remember, it's going to be the same direction as the external intercostals, which are going like this, which are going from lateral to medial. That's going to be the external oblique muscle. So on this slide, I put the cadaveric image in here as well, just to get you to look at it. But basically, if we follow this image, right? So again, like superficial to deep, we have skin and then going all the way to deep, right? So if you picture yourself starting from this star, right? External oblique muscle. So basically, when the external oblique muscle is coming down through the spermatic cord and coming into the scrotum, you can see how if I start this image right here, it's now called the external spermatic fascia, right? The color never changed. The external spermatic fascia is still the external oblique coming from up here. It's just different names. It's called something else because now that it is located inside the spermatic cord as well as in the scrotum, right? So again, know that transition basically as when it goes into the scrotum, it's going to be external oblique turning into the external spermatic fascia, right? And I feel like this picture definitely helps us show like what they're talking about here. So again, this would be the external spermatic fascia, right, surrounding the spermatic cord. Internal oblique, so basically that's going to be from the thoracocolumbar fascia, anterior 2/3 iliac crest, and lateral half of the inguinal ligament. It's not going to be as large as the external oblique, and it's not going to raise up as high either. So again, like the internal oblique only starts from like ribs 10 to 12, unlike the external oblique, which is all the way up here. It starts from like as high as up as rib 6, right? The internal oblique only starts from like roughly around 10 to 12, and it's going to also attach to the linea alba, but via the conjoint tendon in the inferior portion. This internal oblique muscle is going to give rise to your cremaster muscle, right? Your cremaster muscle, which I'll show you on the next slide, again with the same image. I'm going to associate that with the cadaveric one as well, and I'll show you that the internal oblique actually turns into the cremaster muscle, which is going to help with raising and lowering the testes. So you can see on this next slide. So right here, so we have internal oblique turning into the cremaster muscle, right? So we already talked about the external oblique turning into the external spermatic fascia, right? That's the most superficial portion. If we just go deep to that, it's going to be internal oblique turning into the cremaster muscle. So again, if we follow this green right here, right? We follow this green, this light green, obviously, the internal oblique going down into the scrotum, right? Now we see, look, now it's called something different. It's called the cremaster muscle and fascia. So again, when the internal oblique goes into the scrotum, it's actually called the cremaster muscle. And what that does is that, like I said, it's going to raise and lower the testes, or raise and lower the scrotum, the testes, in order to, depending on the temperature, right? So you can see it right here. It's going to be this orange structure wrapping around the testes, right? That's going to be the cremaster muscle. So again, located in this image right here, cremaster muscle. This means that we remove the external oblique, also known as the external spermatic fascia, right? Because in order to see the cremaster muscle, you got to remove the external spermatic fascia, and then you'll see the cremaster muscle just deep to that, right? So they must have removed that in order to see this. The next one is going to be the transversus abdominis muscle. So again, this one's going to be it's going to be on the inner surfaces, actually. So it's going to be on the inside of the ribs, basically the 7th through 12th cartilages, thoracocolumnar fascia, which means it's going to go all the way to the posterior side, right, near the spinal cord, iliac crest, and the lateral third of the inguinal ligament. But what's important to know here is that this is going to be the transversus abdominis, right? The fibers are kind of going transverse, right? Or they are going transverse to the sides, right? So you can see the fibers. So you can point this out pretty quickly based on how the fibers run, because you can see the transversus abdominis is going to be running at a transverse angle, right? And this is just its aponeurosis, right? This right here on top of that would actually be the rectus abdominis, which we'll talk about later. That's what gives you your abs, right? So that would be transversus abdominis muscle. And again, this is the same thing I already put on the earlier slides, so I'm just going to skip this because I talked about this. But again, easiest way to identify these muscles is looking at the fibers, right? So you see this external oblique going from lateral to medial. That you know for sure that's going to be the external oblique, right? Just based on the fibers. Internal oblique just going opposite. You can see that right here. And transversus abdominis, which is going to be going transverse, right? And this is just going to be the rectus abdominis, which we'll talk about later. So again, look at the fibers in regards to cadaveric images. Okay, last one basically. This is going to be the transversalis fascia. Important to know is that the transversalis fascia is always going to be on the posterior side of the rectus sheath, no matter what. Regardless if you're above the arcuate line or you're below the arcuate line, which we'll clear up on the next upcoming slides. The transversalis fascia is always on the posterior side of the rectus sheath. Okay, so it's going to continue over the spermatic cord as the internal spermatic fascia. Right, so transversalis fascia into the internal spermatic fascia. Always going to be on the posterior wall of the rectus sheath. Important to note that. So again, on this slide, here we are, transversalis fascia going into the internal spermatic fascia, right? So let's follow our colors here. So we have our transversalis fascia right here in light blue, like baby blue right here. This is going to be almost the most deepest structure other than the peritoneum, right? Which structure is the transverse going? The transverse is just going side to side. It's going from like lateral, well, it's just going side to side basically, so transversely, just like that. Basically. Okay, so if we follow the transversalis fascia, basically this baby blue right here, going all the way down to the scrotum, right? Come all the way around, bam. There's a different name for it, right? Internal spermatic fascia, right? So again, you can see this transversalis fascia is turning into the internal spermatic fascia, which is going to be one of the deeper layers of the scrotum, right? And the spermatic cord. So again, in order to get this cadaveric image, this internal spermatic fascia, they had to have removed the external spermatic fascia and then the cremaster muscle / fascia as well in order to see the internal spermatic fascia, right? Okay, so all of these structures extend and contribute to the layers of the scrotum except which? A, B, C, or D?
Justin, I think I fell behind on that last slide. So the transversalis fascia turns into the spermatic fascia? Or are they just two different things on two different sides?
I got you. So the transversalis fascia right here, this thing, right when it gets into the scrotum, it's called the internal spermatic fascia, right?
Okay.
You see it? Yeah.
Cool. Yeah, thanks, buddy.
Gotcha. Oh, my bad. I'll get back to the question. Yeah, so is it A, B, C, or D? give you one more minute. Okay. So yes, it is going to be C, the transversus abdominis, right? So that's important to note because we talk about all these like abdominal muscles, right, giving layers to the spermatic cord and the spermatic fascia, right? But the transversus abdominis, you can notice on the slides, I didn't give it anything after we talked about it, right? Because the transversus abdominis doesn't go into the spermatic cord or the scrotum. So that's important to note because that's going to be one of the few abdominal muscles that does not participate in the spermatic cord. Another one that does not participate is going to be the rectus abdominis. So those two muscles will not participate in the spermatic cord. Rectus abdominis, nor would the transversus abdominis muscle partake in the spermatic cord. The other ones that we talked about will. So very good job on that one. Okay. So again, this is just the halfway summary. I just listed, I feel like, the most important things that we just talked about. So yeah, we're halfway through it, yay. Okay, so this is from superficial to deep, right? So I just listed that there. Scarpus fascia giving up its, turning into its three things, the fundiform ligament in the penis, the superficial penile fascia, and the tunicodartos of the scrotum. And then again, this is going from superficial to deep. When going into the scrotum, again, this is going to be the arrows basically turning into what? And again, transversus abdominis does not go into the scrotum, right? So I can't emphasize that enough. It's not going to partake in that. The transversalis fascia will, though, because that turns into the internal spermatic fascia, right? And again, the quadrants, that's important to note as well. So this is just like the halfway summary. Okay. So for the anterolateral abdominal wall, basically this is going to be, if you were to look on the inside of the abdominal wall, basically, so obviously if you section it out and you look on the inside of it, this is what you would see, basically. Yeah, so this is what you would see, basically. So you have actually technically 5 folds, right? Because like there's like 2 on each side. You have 5 folds. So you have the median umbilical fold, the medial umbilical fold, and the lateral umbilical fold. So it's important to know the difference between median and medial. Okay, so you guys know like how you say, oh, this is medial to that, this is lateral to that, right? So those 2 words are used for relations, right? So when you say medial, that is not midline, right? So when I'm talking about midline, that is median. Do you see the difference? Like you use medial and lateral in regards to relation, but median is just for midline. That's just going to be the thing that's down the middle. So again, just so you don't get those confused, obviously, because median and medial sound the same. Think about it when you say, oh, that's medial to that, that's lateral to that. Put those in their own category because those are used for in relation to the midline, right? In relation to other things. Median just means midline, right? So again, if we know that, then we know median umbilical fold is only going to be 1, obviously, because that's on the midline, right? That's going to be over the remnant of the urachus. Basically, what that was just connecting to the connecting the bladder to the umbilical cord, and it was basically just removing urine, right? So that's just basically going to be located right there. The medial, so that's going to be in relation. That's going to be, they're called medial because they're medial to the lateral ones, right? So medial umbilical fold is going to be over the obliterated fetal umbilical arteries, which will be located right here. And then we have the lateral umbilical folds, which will be over the inferior epigastric vessels, right? Those are going to be super important when we talk about the inguinal triangle, direct hernias, indirect hernias. Those are going to be super, super important when we talk about those. But again, note these folds. There are technically 5 of them because there's 1 median, 2 medial, and then obviously 2 lateral, right? So again, so on this slide, I did the same exact thing. I just put an image that was like labeled. I found this image. So it was labeled. Basically, they label it on the right side, but they tell you what it is on the left side, right? So on this right side, they're just telling you median, medial, and lateral. But on the left side, they're telling you what they were, what the remnants were, right? So obviously obliterated urachus, obliterated umbilical artery, and then your inferior epigastric vessel. So technically, the only fold that is still functioning now in all of our bodies is the lateral umbilical fold, right? Because inferior epigastric vessels are still flowing blood as we speak right now. The remnant of the urachus and the remnant of the umbilical arteries are not functioning anymore. They're just folds on the abdominal wall, right? So again, median versus medial. Question? Okay. So inguinal triangle. So that's going to be, again, this is going to be important for us to understand the knowledge of these folds, right? Because a lot of things are in relation to these folds, right? So this inguinal triangle, which is located right here, is technically going to be, it's medial to the inferior epigastrics, but it's going to be lateral to the obliterated umbilical arteries. You can see that right here, right? Right, so you don't want to get confused with your medial and laterals, but if you understand where these folds are, then you should be able to tell where where the inguinal triangle is in relation to these folds, right? Medial to the inferior epigastrix, lateral to the medial umbilical fold, also known as the obliterated umbilical arteries, right? So I don't want you to get confused with these terms, but once you get the folds down, then you should be able to tell where things are in relation to each other, right? What's important about the inguinal triangle is that that's going to be the site of the direct inguinal hernias, right? So direct inguinal hernias are just going to be weaknesses in the abdominal wall, mostly only associated with the parietal peritoneum, right? You're not going to get any spermatic cord as well with that, because when we talk about it later, indirect hernias are going to be associated with the lateral side of the inferior epigastrix, right? So again, when you think direct inguinal hernias, there's two things you should think. One, inguinal triangle, right? And then two, medial to the inferior epigastrix. Those two things are the first two things you should think about when you say, okay, direct hernias, where are these located? Inguinal triangle, also medial to the inferior epigastric vessels, right? If you know what the inguinal triangle is, you basically know that's saying the same exact thing, right? Because medial to the inferior epigastrix and inguinal triangle are both going to be associated with the direct hernias, right? Does that make sense?
Hey, Justin, real quick, what was the thing he said about you put your finger somewhere and then one of them you feel on the tip of your finger and the other one you feel on the side of your finger? What was that?
Yeah, that's going to be like on the last slide. So on the last slide of the left.
Never mind.
Yep, you're good. Okay, so that's going to be those right there. Okay. Then we'll talk about that later on as we go throughout the lecture. Okay, so rectus abdominis muscle and the rectus sheath, basically. These are just images. We're going to skip this. Okay, so basically, we talked about all these pictures. The only ones we haven't talked about is going to be, so basically, if you start off and you go into the anterior abdominal wall, the first thing you're going to see is this in the midline is the anterior rectus sheath, right? If you remove the rectus sheath, you're going to see the rectus abdominis muscle. You remove the rectus abdominis, you'll see the posterior rectus sheath, and the posterior rectus sheath is going to have that arcuate line. That arcuate line is going to be extremely high yield when we talk about that in the next upcoming slides. So these are going to be its associated images. Yeah. He said hernias are much more associated, or much more common in males. That's just due to the indirect hernias, which we'll talk about why when we come into those hernias. But yes, that's correct. Okay. Rectus sheath. So I'm just going to skip this slide, but I'm just going to talk about the same exact thing on this slide on the next upcoming slides, right? So let's move on to the next one. Okay, so yeah. So you have your arcuate line and you have above and below. I remember when I heard this last year, I was so confused because I was like, what is going on? I don't even know what that is. So I'm just going to let me know if it's confusing, because I know it was confusing when I heard it the first time. But basically, this arcuate line is going to be this line that's on this posterior rectus sheath, right? So it's on the posterior rectus sheath, because what happens is that all your abdominal muscles, like the external, the internal, the transversus abdominis, are all going to converge and make that rectus sheath, right? When they get into the midline, they make this rectus sheath, right? But depending on if you're above or below the arcuate line, those muscles are going to switch between being anterior and posterior to that arcuate line in respect to that. So yeah, I'll clear that up right here. So basically, if you're above the arcuate line, right? So that means if you're superior to this dotted line, right? What's going to happen is that anteriorly, you're only going to have the external oblique and half of the internal oblique, right? So you see all of your abdominal muscles converging and making this rectus sheath, right? The rectus sheath is surrounding the entire rectus abdominis. Here's our rectus abdominis right here, right? So you see this rectus sheath surrounding the entire rectus abdominis. But what makes this rectus sheath is all these muscles coming together and fusing towards the midline to cover the rectus abdominis, right? So you see that right here, all these muscles giving way to this rectus sheath. What's going to happen is basically, is that if you're above the arcuate line, you're going to get the external oblique and half of the internal oblique. You see these two contributions? They're both going to be anterior to this rectus abdominis muscle. Right, you see them, right? They're both anterior to the rectus abdominis muscle. Posterior, so behind this rectus abdominis muscle, is going to have the half of the internal oblique, the transversus abdominis, and then the transversalis fascia, as well as the parietal peritoneum. So does anybody need some clarification on that, or can you guys see that, right? You can see what's going on above this line for the rectus sheath, right? Okay.
So just to clarify, so pretty much part of it's going to be covering, like going in front of the rectus abdominis, and the other part's going to be behind that flap, like where it's showing, or is it all behind the flap?
So no, so this is going to be a line on the posterior rectus sheath, and basically, yeah. So it, like for example, the internal oblique and the external oblique, those two parts are going to go cover the front portion of the rectus abdominis, so the anterior portion, so the anterior rectus sheath. You can't see that here because they removed it, obviously, but it's going to be on top of the rectus abdominis. The other half is going to be part of this part, which is the posterior rectus sheath. Does that make sense? Okay. All right, I hope that makes sense.
Actually, go over that one more time, please.
Yeah, I got you. Okay, so
Sorry, like my mic goes in and out, but yeah, it makes sense to me. But yeah, sorry, my mic and chat, they're moving kind of slow for today. I don't know why, but yeah.
no, you're
I
good.
get-
Okay, cool. I'll just say it one more time, but you have the external oblique, and then half of the internal oblique are gonna go anterior to the rectus abdominis muscle. So, like we said, you have the rectus abdominis muscle, which is what makes your abs, right? You have an anterior rectus sheath and a posterior rectus sheath surrounding the rectus abdominis. What makes that sheath? Like we're thinking, what makes that sheath? What makes that sheath is going to be the contributions coming from these side muscles, the external oblique, the internal oblique, and the transversus abdominis, right? So we get that, right? But depending on if you're above the arcuate line or below the arcuate line, some of those fibers are going to go to the anterior rectus sheath, or some of those fibers are going to go to the posterior rectus sheath, right? So when you're above this arcuate line, which is this line on the posterior side, what's going to happen is that when you're above this, so this high up, basically, you have the external oblique and and half of the internal oblique, as you can see, is going to the anterior rectus sheath, right? So it's going to go towards the front side. The posterior side, which is going to be the posterior rectus sheath, is going to take the internal oblique, like half. Okay.
Is that like the layer right below the fat, essentially, the anterior part?
Yeah. That's
like when they say
that's
you
after
can't-
remove. Oh,
Okay.
I'm sorry. Wait, sorry. What
No,
you
go
saying?
ahead. No, go ahead.
No, go ahead. What was your question? Sorry.
No, I was just saying, I know sometimes they say like you have to like lose a certain amount of fat or whatever in order to like your abs to show through, but they would have to show through that, right, the anterior part essentially.
Yep.
But due to the level of fat that's in front of it.
That's most likely the case. Yeah, because I mean the anterior rectus sheath is pretty thin, so that's probably not. That probably won't be. It probably would be the fat. Yeah. Mm-hmm.
It's basically just a thin fascia, right?
Yeah, it's basically what it is. Yeah.
Cool. That's
Like
how I
connective
thought of it. I was just making sure.
Yeah, it's kind of just like connective tissue, like fascia-ish thing. Yeah. All right, so below the arcuate line, basically, so we see this line again right here. Here's the arcuate line. If you below that, you're gonna have all the muscles are going to be towards the anterior side, so they're all going to be part of the anterior rectus sheath. So yeah, you have a thick, strong anterior rectus sheath, but your posterior rectus sheath on the posterior side is going to only be the transversalis fascia and the parietal peritoneum, right? Which is obviously not too good because that's going to be a site for hernias, obviously, because you have weakness in your abdominal wall. Your posterior abdominal wall right here is pretty weak because all you have is your transversalis fascia and your parietal peritoneum. There's no muscle on the posterior side when you're below the arcuate line, right? So it's just going to be these two things located right here, right? So that's the differences between above the arcuate line and then below the arcuate line. Okay. Again, so here's your arcuate line located right here on the posterior rectus sheath, transversalis fascia. We talked about that already. Yep. Again, same thing here. Look at this. You can see external oblique, half of the internal, and then on the posterior side, you have the other half of the internal, and then the transversus abdominis muscle, right? You also, remember, you're always going to have the transversalis fascia and the parietal peritoneum on the posterior side, right? So you're always going to have those on the posterior side. When you said abdominal hernia and inguinal hernia, was the inguinal divided into the indirect, and direct with the abdominal being a third type? Yeah, I think that, yeah, the abdominal is just going to be another type of hernia. Yeah. Okay, so yeah, this is basically the same thing we've been talking about on the previous slides, right? And this is what happens if you're below the arcuate line, right? You see how thin it is behind the rectus abdominis? Like there's literally nothing there, right? So there's weakness in the abdominal wall.
Just a question.
Yeah.
So pretty much above the arcuate line, you get you have like anterior and posterior, but once you get below the arcuate line, the connective tissue from those three muscles only goes anteriorly. Anterior. Yes. Correct. Okay.
Yes. So the only thing you have is that super thin, almost impossible to see transversalis fascia and some parietal peritoneum. That's basically it. So if I was to like point at this structure, obviously he's not going to test you on this, but does anybody know what this structure would be? This one? Does this remind you of anything? So you're looking inside of the abdominal wall. Remember, you have like these. What?
That thing that comes off the stomach. Oh, maybe not. The ones that go to the tensor, the thing that goes into the penis part. I don't remember the ligaments of that. Oh, thing?
the fundiform. It's not necessarily. It's actually going to be those folds. Remember, like we said, the median. Yeah, you're right. Yeah, you're right. It's the median, the medial, and you can't see the lateral, but the folds, right? So this is where they are, right? If you just look on the anterior side, or if you like obviously look inside of the abdominal wall, that would be those folds, right? Obviously he's not going to test you on this image, but I just wanted to like show you like where these are, right? Very good job on that though. Arcuate line. Okay, so the lateral folds on the anterior abdominal wall contain which structures? So A, B, C, or D?
Hey, Justin.
Yeah.
Can you explain what a hernia is exactly?
Yeah, so basically it's just, depending on the hernia, it's just going to be like a weakness in the abdominal wall. So for example, when we say inguinal hernias, you have like your direct or indirect. So in males, you mostly have this indirect hernia because we have our like the spermatic cord, which is going into the scrotum. You can kind of like a hernia is when like, for example, like the parietal peritoneum can get inside of your spermatic cord, thus obviously leaving your abdominal cavity and going into your scrotum, which would be an example of an indirect hernia, right? Your abdominal, like your parietal peritoneum is like compromised, right? You're going into another section of the body where it's not supposed to be. Like hernias are going to be anywhere you have weaknesses in your abdominal wall, leading to either intestines, fat, other things that are not supposed to be located in the scrotum, for example, or other areas in the body. But hernias are most likely associated with males, specifically indirect hernias.
Okay, thank you.
Yep. Okay, so yes, it is going to be A, the inferior epigastric vessels. Excuse me. Does anybody know which fold would be the remnant of the urachus?
Median.
Yep. What about the remnant of the obliterated umbilical arteries?
Medial.
What about superior epigastric vessels?
Nothing.
Yeah, nothing. Yeah, there's not going to be one. So yeah. Yes, very good job with that one. Okay, so inguinal ligaments. So this is just going to run from the ASIS, so the anterior superior iliac spine, to the pubic tubercle. It's just going to form the major floor of the inguinal canal. So again, here are images of the inguinal ligament, and this is looking at it on the interior side of the inside of it, right? I'm going to skip this. There's nothing to talk about here. Okay, so you have your superficial ring, and you have your deep rings, right? So basically what that is that so the spermatic cord is basically coming through this inguinal canal, right? It's going to pop out right through here, right? So this ring right here is going to be the superficial inguinal ring, right? If you go over here, your deep inguinal ring is all the way like back over here, right? So you can think of it as like a tunnel, right? It's kind of like a tunnel. The deep inguinal ring is going to be right when you enter the tunnel, and the superficial inguinal ring is going to be right when you leave the tunnel. That's why you see like this deep inguinal ring, like it's super like deep, obviously. So it's like deep in here. And then your superficial inguinal ring will be all the way over here at the end of the tunnel, right? So the external or the superficial ring is going to be made by the external oblique aponeurosis, right? So basically what happens is that your external oblique is coming all the way down and it's covering over your inguinal canal, right? And it's making that superficial inguinal ring. So this ring right here is made by your aponeuroses of your external oblique muscle, right? Your internal, also known as your deep ring, is made by the transversalis fascia, right? So transversalis fascia makes your internal deep ring. So it's gonna be those two. Okay, so you have your, again, superficial ring. Superior and inferior crus is the same thing as saying medial and lateral crus. I know he labeled them differently, but again, medial and lateral crus are the same thing as superior and inferior respectively, right? Here's our intercrural fibers. The reason why they just call them intercrural fibers is because they're between the cruces, right? Because you have your superior crus and inferior crus. Those fibers in between the cruces are called intercrural fibers. And then you also have your lacunar ligament, which is basically that little triangle, which is connecting your inguinal ligament to the pubis, right? And again, I put a note here. External or superficial ring is made by your external oblique aponeuroses. So this ring right here, external oblique aponeuroses, while your deep ring, also known as your internal ring, is made by that transversalis fascia, right? So that's going to be located, obviously, deeper in here. Okay. Again, we talked about the first two. We talked about this in so many slides already, but I'm going to talk about it again, I guess, just to reinforce it. External oblique muscle. You can see external oblique forms these aponeuroses, which is going to make this superficial ring. So you see this aponeuroses actually comes all the way over here and makes this superficial ring, which is like surrounding the spermatic cord right there. That's why the external oblique muscle makes the superficial ring. We talked about the internal already, and on the next slide, the conjoint tendon. So what this conjoint tendon is basically going to be like this, how do I explain? It's kind of like this like triangle structure, like it's kind of like look like this, looks like that basically. When you remove everything, it looks like that. That's your conjoint tendon. It's going to be made out of the aponeuroses of the internal oblique and the transversus abdominis, right? So your internal oblique and your transversus abdominis converging towards the linea alba, towards the midline, is going to make this conjoint tendon, basically, which is like located right here. That's your conjoint tendon. This is your inguinal ligament. This would be your conjoint tendon. Okay. All right, so we have some fun math here. So basically what you have is transversus abdominis plus internal oblique is going to give you your conjoint tendon. So transversus abdominis and internal oblique give you your conjoint tendon. And then you have your testicular artery and vein plus your vas deferens is going to give you your spermatic cord. Right? So that's going to be your fun math. That's going to be the spermatic cord right here. But it's also important to know that your spermatic cord is also going to have, like, remember we said like your external spermatic fascia, your cremaster, and your internal spermatic fascia are all going to surround your spermatic cord, right? These are just going to be the things that are located inside of it, right? The vas deferens right here, testicular artery and vein, and then this is your spermatic cord, right? So these are the highest of yours that he wants you to understand what is inside of the spermatic cord. These three: testicular artery and vein, and the vas deferens. But what's surrounding that spermatic cord is obviously the external spermatic fascia, the cremaster muscle, and internal spermatic fascia, right? That's going to be located here.
Hey, Justin, so to kind of take just a small step back here,
yeah.
Leading up to the conjoint tendon, you have the inguinal ligament, which pretty much forms the lacunar. And then more medial, that's where the conjoint tendon is made up of these two muscles here, the transversus abdominis and internal, and it kind of just, it like shoots like backwards kind of. So do I have that right?
Yeah. So this transversus abdominis coming towards, this aponeurosis coming towards the midline, and this internal oblique aponeurosis coming towards the midline, make this little triangle towards the inferior portion, this conjoint tendon.
And then lateral to that conjoint tendon, you would have, and going superior, you would have the lacunar and then the inguinal.
Yeah, the lacunar you can't see would be inferior, and then this would be the inguinal ligament.
Okay, cool.
So is the inguinal ligament like part of the external oblique muscle, or is it just connected to it?
No, the inguinal, it's actually, it's kind of connected to it, but the inguinal ligament is its own structure because it only connects from the ASIS to the pubis. So like in this, I'll show you in this picture. It's a little weird, but you see this is the inguinal ligament connecting, but it still has some portion of the external spermatic fascia. Like this right here, this like portion is like some part of the external spermatic fascia, right? So like,
okay.
Obviously.
Yeah,
so
I wasn't sure. The wording on the slide had confused me that he had posted, so that's why I wasn't sure if it was like a continuous structure or if they were two. Okay, thank you. And actually, since I'm asking questions now, can I ask one more question about the parietal peritoneum? Now, is that on the, like, what is, I feel like we've kind of like brushed over it in like all the lectures, but I don't really understand, I guess, where it is and what it does. Is that just on the back side?
Yeah, so in the next lecture when we have with Dr. Wiernowska, she's gonna go like all over this like parietal and visceral peritoneum. But basically what it is it's just the area that's surrounding your abdominal cavity, basically. So what keeps all your organs in place, like not dropping down into your legs, obviously, right? Okay. So that's what your parietal peritoneum is. So
that's deep to the transversalis fascia.
Yes.
Got it. Thank you so much.
You're welcome. Was this the top of the femoral triangle inguinal ligament? Wait, are you talking about like in this picture, Gabrielle?
Oh, I think that may be from the last lecture, like the femoral triangle from the leg.
Oh yeah, is she saying are those different? What is this? Was this the top of the femoral triangle? Yeah, it was. Yes, it actually was. Yeah, and the inguinal, the femoral triangle also has its. You also have the inguinal triangle as well. Yeah, the inguinal ligament does take place or does have borders in regards to both of those. Okay, so where were we? I think we were. Did we talk about this? Yeah, we did. We did our fun math. Okay. Again, so this is exactly what we talked about on the last slide. So, yeah, for sure. Basically, for females, the only thing that runs through the inguinal canal is going to be the round ligament of the uterus and the genital branch of the genital femoral nerve. I mean, you also have the ilioinguinal nerve that runs with both the males and females. So basically, you have like this ilioinguinal nerve that runs through the inguinal canal. It doesn't run inside of the spermatic cord, right? So like your spermatic cord is going through your inguinal canal, but you have like just like outside of that, like running like right next to it, like kind of parallel is your ilioinguinal nerve. It runs just with it. It's the same with males and females. So in females, your inguinal canal is only going to have the round ligament of the uterus as well as the genital branch of the genital femoral nerve. And what that is basically that's just the fancy way of saying nerve to the cremaster muscle. The nerve to the cremaster muscle actually comes off the genital femoral nerve, which is called genital branch. It just supplies the cremaster muscle in males, but it'll supply something else in the females. But that's going to be the inguinal canal, right? For the females, and then we talked about the spermatic cord and then the inguinal canal in males. We'll talk about that a lot more too in the next section.
Justin, okay. On that slide, I think I got confused. The ilioinguinal nerve is the genital branch off genital femoral, or are those two different nerves?
Yes, those are two different nerves. The ilioinguinal is in males. I mean, everybody has ilioinguinal, which is going through the it's going through the inguinal canal, right? It's going through the inguinal canal, but it's not running with this. It's not inside of the spermatic cord, is what I'm saying in males. It's not inside the spermatic cord, but it's still running through the inguinal canal. It's like running just parallel to that. In females, it's obviously running in the inguinal canal, and females don't have a spermatic cord, so it's running in the inguinal canal. Does that make sense?
Yes, thank you.
Okay, got you. Okay. Yep. Same thing here. I just put this on a lot of slides just to help you remember. External ring with the external oblique aponeurosis, internal and / deep ring with transversalis fascium and conjoint tendon. This is your fun math, basically, that you saw on the last slide. Basically, what these rings are, like we said, we talked about the rings, the superficial rings, etc. Oh, wow, perfect. Yeah. So this is the ilioinguinal nerve. So wow, perfect. Yeah. So you see how like the ilioinguinal nerve is running through the inguinal canal, but not inside the spermatic cord. That's what I meant when I said like, your ilioinguinal nerve is still going through your inguinal canal. It's just not inside of your spermatic cord, right? It's the same thing with males and females. So that runs through the inguinal canal.
Thank you.
Oh yeah, for sure. Okay, and then here are the rings, basically A, B, C, and D. This is just like obviously like just the rings of the inguinal canal, and they basically help with. So when you're coughing or like increasing abdominal pressure, basically they help with not like obviously damaging your peritoneum, right? Not like putting too much pressure on your peritoneum. That's what those rings are for, basically. Nothing important on this slide. This is just an image. Gonna skip this. This is just know that your arterial, venous, and lymphatic supply of the testes are just going to originate from the abdominal region, right? Abdominal area. Just because the testes are going to originate from such like a high area, basically, so near the kidneys, and it's going to be supplied by anything that's coming from the abdominal area. Nothing here. This is just a picture. Again, like I said, Only thing going through the inguinal canal, round ligament of the uterus, genital branch, and genital femoral nerve. There's obviously more things like going through the inguinal canal, but they're like super minor structures that he doesn't want you to know. But the relevant structures, obviously, that go to the male and females are the ones that I'm listing, right? So, again, these are going to be these two, round ligament of the uterus, genital branch, and genital femoral nerve, as well as the ilioinguinal nerve, right? That just runs through the inguinal canal. And what the round ligament of the uterus is, basically what it is, it keeps the uterus antiflex, basically. So, or right here in this, so you see this like you see this round ligament. It's kind of like, it's keeping like the uterus in place, basically. That's what it does. So that's the round ligament of the uterus. Nothing too important here. Okay, so basically your inguinal canal, basically you're gonna have the roof, the anterior wall, the floor, and the posterior wall. So the best way to remember like the borders of this inguinal canal is going to be malt. So like that's the way, like I feel like is the best way to remember. I'll show you on the next slide what I mean by that. But what that means is that, so it's gonna be muscles, aponeuroses, ligaments, and tendons. So malt is gonna stand for muscles, aponeuroses, ligaments, and tendons. So you'll see on the next slide how I'm gonna use that basically in order to remember the roof, the anterior wall, the floor, and the posterior wall. So this slide. So basically you have malt basically. So if you draw like let's just say you draw like a 3D square like this, right? And you label malt across just like this, right? So just like this, you make this 3D square. M would be the superior, which is the roof, right? So M would be the roof, A would be the anterior wall, L would be the inferior, and then T would be the posterior, right? So what this stands for is going to be muscles, aponeuroses, and ligaments and tendons. So for the roof, basically the roof of the inguinal canal, you're going to have malt. That's going to be M, right? So it's going to be your muscles. So you're going to have the internal oblique and the transversus abdominis muscles. So those two muscles are going to make the roof of your inguinal canal. Your anterior wall is going to be A in malt, right? Which is going to be your aponeuroses. So the aponeuroses of the external and internal oblique are going to make the anterior wall. You see that right here? It's going to make the anterior wall. Your inferior border, that's going to be ligaments, right? So also MAL, so ligaments. That's going to make the floor of the inguinal canal. And that's going to be the inguinal and the lacunal ligaments. Those are going to make the floor of the canal. And then the T is going to be the posterior wall, which is going to be tendons. It's going to be your conjoint tendon and your transversalis fascia, right? So everything is going to have two structures associated with it, right? So the roof, the anterior wall, the floor, and the posterior wall, all going to have two structures associated with it. But the easiest way to remember it is going to be muscles, aponeuroses, ligaments, and tendons, right? So just to help you organize yourself in regards to that. And this is what the inguinal canal is going to look like if you were to do like a longitudinal section like that. So again, I would draw the malt like this, basically, M-A-L-T, in a circle just to help you remember the muscles, aponeuroses, ligaments, and then tendons. So on the posterior side, right? Yeah, so that's going to be your inguinal borders, basically. Nothing here. We talked about this already. Hernias. Okay. So the processus basically vaginalis should fuse together once the testes descended. That's just basically going to be the space between the parietal peritoneum, which is located right here. Obviously, it should close together once the testes has descended. That's the only thing he noted on the slide, so that's the only thing I would note. So processus vaginalis should fuse once the testes is descended. Again, rectus abdominis and the transversus abdominis do not contribute to the surrounding testes, right? So again, your rectus abdominis, which is your abs basically, and your transversus abdominis, which are the things that are going transversely, do not contribute to the surrounding of the scrotum or the testes, right? Okay, and this is going to be your obliterated umbilical artery. Which fold is this going to be?
Medial.
Yeah, so the medial fold, right? So really good. This would be your inferior epigastric artery, so this would be a lateral fold, and you can't see the median fold, right? Again, inguinal triangle, like I said, direct hernias, right? So two things you got to think about when you see direct hernias. Do I have it on the next slide? No, I don't. I guess I have it in the next lecture. Okay. Two things I need to think about when you see direct hernias is going to be inguinal triangle and medial to the inferior epigastrics, right? So when I say, okay, direct inguinal hernia, I'm thinking medial, inferior epigastrics, and inguinal triangle, right? Indirect is going to be lateral to this. All right, and the reason why it's lateral, so you can see how like these intestines are going into the, it's going in and descending into the scrotum lateral to the inferior epigastrics, right? So this has to be an indirect hernia, right? Because indirect hernias are lateral to the inferior epigastric, right? This is the inferior epigastric. Direct hernias, which is going to be located right here, are going to be medial to the inferior epigastric, right? Also known as inguinal triangle. Again, indirect hernias are 20 times more common in males, just because of the spermatocord just descending into the scrotum, and then they're also prone to strangulation, right? So if you think about it, if your intestines are just going into your scrotum, right, it's obviously like some strangulation is bound to happen, right? So that's why indirect hernias are very dangerous in regards to strangulation. If you have intestines going down there, right, it can lead to necrosis of that. Okay, so in an indirect hernia, basically, so with indirect hernias, you're going to have peritoneum as well as the coverings of the spermatocord, right? A direct hernia is only going to have a peritoneum. That makes sense, right? Because direct hernias, it's only going to be covered by peritoneum, but indirect hernias is covered by the peritoneum as well as the coverings of the spermatocord, right? Because it's descending downwards. And this is just a clinical case that he went through. And basically, I would just note, did I put this on the next one? I thought I put this on the slide. Okay, I'll update this because I'm pretty sure this is the one I didn't. I had this little something here. Okay, so basically, the only thing I would note is that that the tip of the finger is going to be associated with an indirect hernia, and the side of the finger is associated with a direct hernia, right? So again, in this one, it says that the physician is feeling basically an impulse in the pushing in the tip of his finger. If you feel in the tip of the finger, it's basically going to be an indirect hernia, like he stated here. And if it's the side of the finger, it's associated with a direct hernia, right? So I would write those down. I would note that. But other than that, this is just a clinical case just to get your mind going. And that's it. Any questions before we move on to the next lecture?
Quick question, Justin. I'm sorry. I know you've gone over it like 600 times. So when you say medial and lateral folds, you're talking about like the medial fold that has the umbilical artery that we don't use anymore, and then the lateral fold has the inferior epigastric artery.
Yes, and vein, artery and vein.
And vein. Yeah. Okay. I'm sorry.
You're good.
I was confused on that.
No, you're good. Yeah. No, feel free to ask me any questions, y'all. Like, I don't mind. Okay. All right. Let's pull up this last one. Any questions before we start, or you guys want to just head right into it?
Veer had a question in the chat.
Oh, let me see. Yeah, so the indirect hernia, it goes through the deep inguinal ring, and then it's going to pass through the superficial inguinal ring into the scrotum, basically. So yes, that is correct.
And the direct hernia would only go through the superficial?
So it depends on where the direct hernia is. It could go through the superficial, but likely it's just going to be on the peritoneal wall.
Thank you.
Where again do you palpate when you're checking for the hernia type?
Yeah, so basically you're putting your hands like this, kind of but against your inguinal canal. So in your groin area, you put your fingers there, and if you feel it on the tip of your finger, it's a indirect.
Okay, cool. Can you show me? No, I'm just kidding, dude.
I was like, nah.
All right, thanks, man.
I was gonna put a picture of it too, but I was like, you know what? Nah, it's too much. Okay. Let me get lecture 4 started. Okay. Can you all see this, my screen, or no?
See the old slides?
Oh, you can see the new one yet? Yeah, it's weird. Okay. Okay. Can you all see that?
Yeah.
Yep.
Okay. All right. So we're gonna go through the posterior abdominal wall, and then I think we'll talk about hernias even more here. But yeah, we'll just get right to it. I'm gonna skip those. Okay. So basically, you have 5 lumbar vertebrae, and then we're gonna talk about the posterior abdominal wall. Basically, that's gonna be on the posterior side of your abdomen. We'll talk about the kidneys. We'll talk about those muscles as well that are associated with the posterior side. And you also have your 5 lumbar vertebrae, right? So L1 to L5. The posterior abdominal muscles, I would for sure note that you have 4 of them. It's going to be quadratus lumborum. your psoas major and minor, and then your iliacus, right? Those are going to be the muscles that are associated with the posterior abdominal wall. Okay, hold on. Okay, so quadratus lumborum. So basically, I mean, feel free to follow this slide, but basically on the next slide, I showed you again what the quadratus lumborum looks like. And again, here's where it is. You can see your quadratus lumborum is attaching to these transverse processes right here of these lumbar vertebrae, and it's only going up to roughly like rib 12. You see it right there. And the innervation is going to be T12 to L4, right? So you can see that here, the quadratus lumborum coming from T12 all the way to L4, and its innervation is going to be T12 to L4. And one of its main actions I put is that it unilaterally flexes the trunk, right? So it's obviously going from the side to side, basically flexing the trunk. It also helps with stabilizing the 12th rib in regards to like inspiration. So when like you're inspiring, stuff like that, it holds the 12th rib in place, right? So that's what your quadratus lumborum muscle is, and this is going to be on the posterior side, right? So like basically almost in your back, right? But obviously not like as superficial as that. So this is going to be on the posterior side, quadratus lumborum. Your psoas major. So again, I would note that your psoas major is going to run with your psoas minor, right? So you know your psoas major, psoas minor, as well as your iliacus muscle. So remember when your iliopsoas, remember when we talked about that before, because your psoas major runs with your iliacus, they become one muscle when they cross obviously the os coxae and eventually join the lesser trochanter of the femur, right? So they attach the lesser trochanter of the femur, and those are going to be those two muscles. So the psoas major specifically, though, remember it's only going to be innervated by L1 to L3. So you can see this psoas major attached to these lumbar vertebrae, and it's attached to this lesser trochanter of the femur. So when this psoas major contracts, basically it's going to pull the thigh upwards, right? So, but it's also going to flex the trunk, right? So flexes the trunk and flexes the thigh. The reason why it does that is because it starts from the trunk, right? So it's going to allow you to flex the trunk as well as flex the thigh, right? Because it crosses here as well as here, right? But its innervation, remember, is going to be L1 to L3 for psoas major. It's not going to be the femoral nerve. Femoral nerve is going to be the iliacus. We talked about this like in the last block. I don't know if you all remember, but remember the iliacus is going to be the femoral nerve, but the psoas major is going to be L1 to L3. Okay. And here's our iliacus basically. So again, it runs with your psoas major, right? So it runs with your psoas major, and it's going to attach to the lesser trochanter of the femur, and it acts in hip flexion, right? That's all it does. And again, its innervation is the femoral nerve. So on this slide, you can see your iliacus muscle right here, joining on the lesser trochanter of the femur with the psoas major muscle, right? So with the psoas major muscle making the iliopsoas. But again, the iliacus muscle innervation is the femoral nerve, which is going to be L2 to L4. In its actions is going to be flex the thigh, right? So it's just going to flex the thigh. So which of these matches are incorrect? So is it going to be A, B, C, or D? Quick thinking. Can I go back a slide? Does psoas minor connect back into the psoas major? No. So basically, the psoas minor is basically going to just connect to the the pubis, basically. Pubis / yeah. So it just attaches to the os coxae. The psoas minor has like no function basically in anything. It doesn't do anything actually. So that's why only like not everybody had the psoas minor, and they actually believe that later on, eventually, like people aren't just gonna have them anymore. So because it has like absolutely no function to it. Yes, I'll go back a slide right after I finish this, Kaylee. Got you. Okay, so it is going to be A, right? So yeah, I know it's a little hard to answer these questions like just right off the bat, but again, this is used for your studies all as well, so you can go back to this later. But again, the psoas major is going to be getting rami from L1 to L3, but your iliacus, remember, is your femoral nerve, and your quadratus lumborum is just going to be rami from T12 to L4. I'll go back a slide. This slide right here, Kaylee. Is there anything you want me to go over? Is this good? All right, so basically you're gonna have your psoas major and your quadratus lumborum, basically, but your quadratus lumborum, remember, is going to be lateral to your psoas major and posterior to your kidneys, right? So your quadratus lumborum, you can see it's posterior to your kidneys, but it's going to be lateral to your psoas major, right? So the most medial one is your psoas major, and then your quadratus lumborum is going to be slightly lateral to that, right? So I would note that here. Okay, so the respiratory diaphragm, so basically the skeletal muscle is going to be arranged radially, basically. So you can see like you have your central tendon in the middle, and you have all the muscle fibers surrounding it, basically coming up into the central tendon, right? He talked about these different portions, basically the sternal portion, the costal portion, and the lumbar portion, which is why I put this image right here just to help you with that. But basically the sternal portion is just the portion of the diaphragm that's posterior to the xiphoid process. So you see this is the xiphoid process, and the sternal portion is just the portion just posterior to that, right? Your costal portion is just going to be associated with your ribs, so posterior to these ribs, so the inner surfaces. And then your lumbar portion, which is located right here, is going to be associated with the crus, right? So the right and left crus, right? So you see these cruces right here. That's the lumbar portion. So I put this image in there. I feel like it really helps in regards to what the sternal, costal, and lumbar portion is. So I just dropped that in there for y'all. And again, the connective tissue, or the central tendon, is going to be just connective tissue, right? So this white portion right here is just the central tendon, which just contains connective tissue. Okay, so this is going to be important, actually really important for us to understand. Again, remember we have our IVC, our I ate 10 eggs at 12, which I'm about to eat after this. It's going to be IVC is going through T8, right? So I8, that's going to be IVC through T8. Esophagus is going to be through T10, and then your aorta is going to be through T12, right? So we're going to have these things called these medial and lateral arcuate ligaments, as well as median, right? As well as our median. So again, this is not the first time we see this, right? So remember we saw about the folds. We have median, medial, and lateral. It's the same thing here. We have a median, which is midline. We think median, think midline, medial, and then lateral, right? So it's 100% important to note what goes under these arcuate ligaments, right? So what goes under the medial one is going to be our psoas major, right? What goes under the lateral one, the lateral arcuate ligament, is going to be our quadratus lumborum, right? That's going to be super high, I feel, in regards to understanding what these ligaments are, right? Can anybody just guess what will go under the median arcuate ligament? What do you think? So median, midline.
The aorta?
Yeah, the aorta, right? So yeah, so the aorta is going to be going through the median arcuate ligament, right? So that'll be that. And you always have the same thing on the opposite side, right? So medial, lateral. So again, I definitely note those. And then we'll talk about the right and left crus on the next slide, I believe. Yes. Okay. So I basically put the same thing here that's on the last slide. I feel like this picture's high quality. So basically, you have your median, which is your aorta, right? Your median arcuate ligament, your esophageal, your median arcuate ligament is going to be where your aorta goes to, right? That's really important. Do T12. Medial, psoas majors, and lateral is going to be quadratus lumborum, right? So you can see that in these images. And again, what's important to know is that what makes your esophageal hiatus is going to be your right crus, right? So you can see this right crus right here you see it's like dotted line. It's surrounding the esophagus, right? So only the right crus of your diaphragm makes your esophageal hiatus, basically. So that's going to be only the right crus. That's super important to note. The right crus. So if you have a loosening in your right crus, what do you think? What do you think can happen? Like if your right crus is loosened, what do you think can happen?
Stomach's gonna go up your diaphragm?
Yes. So you can have a hiatal hernia, right? So your stomach can go up into your diaphragm. You have the loose right crus, right? So again, your right crus is super important in obviously making sure that you're not just your esophagus is not too loosely going into the stomach. So yes, loose right crus can lead to a hiatal hernia, right? And then you have both the right and left crus again are going to be associated with the median arcuate ligament, right? So aortic hiatus, median arcuate ligament, they're the same thing, right? Because the aorta is going through there, but both the right and left crus make those, right? So that's going to be associated with this image as well. Okay, so here's the diaphragm. Here's our I ate 10 eggs at 12, your IVC, esophageal hiatus, as well as your aorta, right? Here's going to be your median arcuate ligament. right? So your median arcular ligament is going to be made by your right and left cruce, right? But your esophageal hiatus is only made by your right cruce, right? Does that make sense? Okay, good. And then note that, again, I would just note this. He talked about it a little bit. I would just note it that the right phrenic nerve is going to pass through the IVC at T8. So obviously your phrenic nerve is going to supply your diaphragm, right? It slightly passes the IVC, or slightly passes at T8, and then your vagus nerve is going to pass with your esophagus, right? So the way I like to remember that the vagus nerve passes with the esophagus is that because like your vagus nerve is super important in like innervating parasympathetic innervation of like your entire like gut, basically, like so much of your gut. And your esophagus goes to your stomach and eventually to your gut, right? So that helps me remember that the vagus nerve is going to pass with the esophagus, right, at T10. That's going to be that. Again, I ate 10 eggs at 12, caval, which would be at IVC at T8, esophageal at T10, and the aortic at T12, right? So those are going to be those. Let's see. So you have your sympathetic and parasympathetic to the abdomen. So again, sympathetic trunk is basically going to be running on the lateral sides of your vertebrae, basically. So going down your vertebrae, your sympathetic trunk is running down the lateral side, almost close to like the transverse processes. Remember the side things that are coming out of the vertebrae? That's your sympathetic trunk, basically, just going straight down, basically. So this would be located right here, your sympathetic trunk going straight down, and then here are going to be like a sympathetic ganglion, basically. But again, your right vagus right here, right vagus nerve. Can anybody tell me what this would be then? What would this ginormous structure be? What is
esophagus?
Yeah. So this would be your esophagus, right? Because the vagus runs with your esophagus, and this, what would this be? This huge thing.
Your stomach?
Yeah, your stomach, right? So you see what I'm saying? So your vagus is going to be running with your esophagus is going into your stomach. You can see that if your right cruce, for example, is loose, this portion of your stomach can potentially go up into your diaphragm region, right? So again, you don't want to have a loose right cruce. Not like rhymes, I guess. You don't want to have like a loose right cruce. So again, vagus, like I said, which comes from the cranial region, which is actually a cranial nerve, is going to provide parasympathetic innervation. And then you have your sympathetic trunk, which is going to do the sympathetic innervation coming from the thoracocolumbar region, right? I just think it's nuts that like the vagus nerve comes from like the cranial region and like goes all the way down and supplies your digestive tract. I just think it's like amazing. Yeah, so that's what your vagus and your sympathetic trunk is coming from your thoracocolumnar region. Okay, so again, note, like I said, right phrenic nerve is going to pass through the IVC at T8, and then you have your vagus nerve passing your esophagus around T10, right? So I would note those. So innervation of the diaphragm from the phrenic nerve, spinal nerve number C3, 4, 5 keeps you alive. That is going to be your phrenic nerve, and it's going to run anterior to your hilum, right? So your phrenic nerve runs anterior to your hilum, which is going to be the things that connect to your lungs, right? So that's going to be your phrenic nerve. Okay, so when he talked about this, basically he said that we know that the diaphragm is supplied by the phrenic nerve, right? But the peripheral parts of the diaphragm is actually going to be supplied mostly by the intercostal nerves. And what happens is basically if you have diaphragm pain, basically, it's mostly going to be associated with your shoulder, basically, your shoulder region, based on the dermatomes that are associated with that, especially since it's going to be associated with the peripheral parts of the diaphragm. So I'll show you on the next slide what I'm talking about. So like you can see here, basically, if you have like pain in your diaphragm, so for example, like in your, let's just say in your gallbladder, right? If you have pain in your gallbladder, let's just say your gallbladder is like inflamed and it's putting pressure on your liver, right? If it puts pressure on your liver is going to put pressure on your diaphragm, right? If it's putting pressure on your diaphragm, that's going to lead to right shoulder pain, right? Because we know it's going to be on the peripheral side, because if we know the liver is mostly associated with the right side of your body, right? It's like the right upper quadrant. That's going to be referred pain to the right shoulder if it's gallbladder. Appendicitis is most commonly associated with umbilicus region pain, obviously early on. So if it's early on, later on, obviously if it gets worse, you'll mostly feel it where your appendix is. But early on, it's usually associated with umbilicus region. And again, irritated diaphragm is usually associated with right and left shoulders, right? So I put this little thing here because these are the highest yields that he talked about during lecture. So I noted them right here for y'all in regards to referred pain.
Hey, Justin, quick question. In lecture, he mentioned for the appendix, like the initial pain is in the umbilicus region, but then later as the appendix gets more inflamed, it's in the right lower quadrant. if he were to ask us a question about that, he would have to specify whether it's like early on kind of pain or late, correct?
Yeah, he would, and I doubt he would say umbilicus region versus like the where the appendix is, if he would, because then it's like it could be both areas, and depending on how early it is.
Okay, thank you for clarifying.
Yeah, of course. Okay, and that's referred pain. Is radiating pain a form of referred pain? I'm not too sure. I think so. I'll have to double check that for you though. Okay, so hiatal specific. Remember the esophageal sphincter is made from the right crus, right? So that's what we said. Hiatal hernia right here. So which structure goes under the, this is going to be a throwback, so which structure goes under the lateral arcuate ligament? The psoas major, the aorta, the quadratus lumborum, or the iliacus? Lateral. Give you one more second. All right, so it is going to be, yes, C, quadratus lumborum. Okay, so I literally just thought of something right now that I feel like would be an easy way to remember going from median to medial and lateral. So basically, under the median one, we talked about the aorta, right? Going under that. The medial, it was going to be the psoas major, right? Yeah, and then the lateral one is going to be the quadratus lumborum, right? So basically, it just goes in alphabetical order. That's what I had to clarify that in my head. But basically, it just goes in alphabetical order. So you have your aorta, then your psoas major, then your quadratus lumborum, right? So A, and then obviously your psoas major, it's P, and then Q, which would be your quadratus lumborum. So if you want to use that to remember it, that can help you remember that it goes aorta, psoas major, then quadratus lumborum. So it's basically going like alphabetical order outwards. I literally just thought about that right now. So if that helps you, feel free to use that. Psoas major extends down to the leg and is also found under the lateral. What? Wait. What's your question, Sophia? No, it's actually found under the medial arcuate ligament. Your quadratus lumborum will be on the lateral, and then you have aorta down the median. Okay. So blood supply for the diaphragm. Okay, no, you can. So blood supply for the diaphragm. So I just flipped this. I put thoracic surface over the abdominal surface just because I like to talk about like from top to bottom. So thoracic surface means on like the top side. Abdominal surface means like on the side facing the abdominal cavity. And basically, yeah, it's for sure high yield to know all these structures, which is going to be the thoracic surface, which would be the pericardiophrenic arteries, the branches of the musculophrenic arteries, and the small superior phrenic arteries off the aorta. I'll show you on the next slide, but the abdominal surface is going to be the inferior phrenic arteries as well as the first pair of arteries off the abdominal aorta. So on this next slide, it'll do us a lot of justice in regards to understanding how these blood supplies are going into the diaphragm. So I found this picture and I feel like it really helps. So basically on the thoracic surface, meaning the top surface, right? This is the top surface of the diaphragm. You're going to have your pericardiophrenic arteries. Remember when we talked about our internal thoracic, right? That's part of our vitamin C and D. Remember throwback, and we also had like the screw the lower saver patient for axillary artery. So the vitamin C. So your eye is the internal thoracic. Your internal thoracic is basically going to branch off into the pericardiophrenic artery, right? So your internal thoracic is coming down here, branching off into your pericardiophrenic artery, and that's going to go straight down and supply your diaphragm. Your your internal thoracic keeps going down, and basically what's going to happen is it's going to split into the musculophrenic arteries. Right, the musculophrenic arteries, which is then going to also supply the diaphragm. So you see right here, splitting again to form the musculophrenic arteries to supply the diaphragm. And then lastly, you also have the superior phrenic arteries, which will be coming off the diaphragm right here. You can see them right here, coming off the diaphragm, coming off the aorta, supplying the superior portion of the diaphragm. So I hope that makes sense, basically, in regards to where these arteries are coming from, because I didn't want you to just memorize random arteries. I wanted you to really understand where they're coming from, so you understand, okay, that makes sense why the pericardial phrenic coming from the internal thoracic is supplying the top portion of the diaphragm. Same thing with musculophrenic, and the same thing with the superior phrenic artery, right? So it's going to be that one. Abdominal surface, inferior phrenic arteries, right? We also talked about like the first like costal arteries, like we talked about like on the last slide, first pair of arteries coming off the abdominal aorta. I mean, you can note that too, but this one's a little bit higher yield. Inferior phrenic, you can see inferior, taking the inferior portion of the diaphragm, right? So that's going to be inferior phrenic arteries via the abdominal aorta, right? So the first two are givens, right? So because superior phrenic arteries taking the superior portion of the diaphragm, inferior phrenic arteries taking the inferior portion of the diaphragm, right? Also known as abdominal surface. And then you just have to learn these two basically. But I showed this image, so hopefully that helps with the branching. Lumbar plexus. So yes, we have to know all these. So don't worry. I broke them down on the next following slide, so we understand what is going to be what we need to know for the lumbar plexus. So I'm going to skip this slide, but I'll show you what we're going to talk about on the next slide. It's going to be everything on this slide. Don't worry, we're not going to miss anything. So how do you take an anatomist on a date? So interested in getting lunch on Friday is going to be the best pickup line to take somebody on a date. So an anatomist would be thinking this. So why do you think that? Because this is going to be the perfect mnemonic in regards to remembering what is going to be the branches off of the lumbar sacral plexus, the lumbar plexus specifically. So interested in getting lunch on Friday, right? So that's going to be, and this person, of course, a very well knowledgeable person in regards to the lumbar plexus, doesn't think about going on a date, but more so thinking about the lumbar plexus, right? So very good job. So you have interested in getting lunch on Friday. So here we are on the next slide. So it's going to be the I in interested is going to be your iliohypogastric. So that's going to be L1. You have your ilioinguinal, which is going to be L1 again. And then you also have, so like iliohypogastric and ilioinguinal, I know they kind of like, it's hard to remember which one comes first. So I put something there, H before I, right? So basically H before I, wait, A, B, C, D, F, G, H, I. Yeah, so yeah, H before I, right? So you have iliohypogastric and then you have ilioinguinal. That would have sucked if that was wrong. But yeah, so iliohypogastric and then you have ilioinguinal. So they're both coming off of L1, right? And then you have genital femoral nerve, L1 to L2. He did say he wants you to note the spinal levels, which is why like the mnemonic is in the same order, right? So interested in getting lunch on Friday. So that is in the same order that the spinal levels are coming off of. So this would be the genital femoral, L1 and L2. Lateral femoral cutaneous, L2 to L3. Obturator, L2 to L4, and then femoral as well as L2 to L4. So basically, this is going to be the mnemonic I feel will help you to remember the lumbar plexus going from superior to inferior. Also important to note, on the last slide or the last two slides, he also talked about the accessory obturator nerve. That's part of the lumbar plexus, but nobody really talks about it too much because only like 20 or 25% of people have an accessory obturator nerve. Very, very low amount of people actually have that. But he did put it in there. Even if you look at it online, like it's not that many people have it. But I would note it though, just in case. He did put on this slide that the accessory obturator nerve also comes off. And what the lumbosacral trunk is basically just going to be the connector from the lumbar plexus to the sacral plexus, right? So here's your lumbar plexus. Your lumbosacral trunk comes just inferior to all this, which is to be located right here because it comes from L4 to L5. And it's going to be like basically like that kind of like connection between, that's why it's called like lumbosacral trunk. It connects the lumbar plexus and the sacral plexus. And that's what it does, right? And again, lumbar plexus formed by rami L1 to L4, right? So L1 over here, all the way to L4 and femoral nerve, right? And again, super important to know is that your subcostal nerve is not part of the lumbar plexus, right? So subcostal nerve is not included, right? I know it's superior to the iliohypogastric, but it's not included in the lumbar plexus because it is going to be like a kind of like an intercostal, but it's obviously called subcostal because it's under the rib, right? Okay, so again, so we went through this already. Interested in like getting lunch on Friday. So you have the subcostal nerve. This is obviously not in the same order because he just pointed at different things. But again, subcostal nerve is going to be the most superior here. But again, it's not associated with the lumbar plexus. and then the nerves in relation to the psoas major. So we talked about it in class, but we've talked about this a lot before. Remember that the genitofemoral nerve goes over the psoas major, your femoral nerve is lateral to the psoas major, and your obturated nerve is going to be medial, right? Okay, so so then this is just the contents that we talked about in the last lecture, but I put it again here. So just to remind you that, again, the female inguinal canal contents, the relevant ones that we talk about, obviously there's a little bit more. The round ligament of the uterus, the genital branch of the genitofemoral nerve, and the ilioinguinal nerve. Remember, I said like the ilioinguinal nerve goes through the inguinal canal, but it's not inside of the spermatic cord, right? It's just going through there, right? It's just parallel to it, right? And again, in the male, we talked about the spermatic cord, which is surrounded by all these fascia and muscle, testicular artery and vein, and vas deferens. But you're also going to have genital branch of genitofemoral nerve, as well as the ilioinguinal nerve, right? So this is going to be for your studies. Okay, so this is just basically everything associated with what we just talked about. So interested in, basically, this is your iliohypogastric and your ilioinguinal. So it's kind of easy to identify them because they kind of do this. Basically, they look like a, not like a peace sign, but they kind of look like this when they're coming out. So that's how you can basically point out the iliohypogastric and ilioinguinal, because you can see the iliohypogastric right here, superior, and the ilioinguinal just inferior to that, right? And then this is going to be the getting lunge. So genitofemoral nerve going over the psoas major. And then you have your lateral femoral cutaneous coming around the iliacus. And again, on Friday, which is going to be the obturated nerve, which is just medial. So again, if we understand what's in relation to the psoas major, then we should be able to pick up what these nerves are, right? Because, for example, like we know this is the femoral nerve because it's just lateral to the psoas major. And the femoral nerve is a very large nerve. So it's hard to miss, basically, because we know the femoral nerve innervates a lot of the thigh, right? Like, look how thick this nerve is. This is the femoral nerve, right? Look at that. It almost looks like a tendon, basically. It's almost as thick as this artery, right? So the femoral nerve is really thick. It's a big, big nerve. So it's hard to miss that one. And then you have an obturated nerve right here. Oh, yeah, and this. So basically, I just found this. I found this picture, and I thought it worked perfectly with the subcostal nerve. So basically, this is just saying that lumbar plexus is like, you're not welcome, basically. So the subcostal nerve is not part of the lumbar plexus, and it's going to be obviously its own thing, which is why I put it right there, right? So obviously the subcostal nerve can't sit with us. So here's the lumbar plexus, and here's sorry, not sorry, right? So hopefully that can help you remember the subcostal nerve. Okay, so posterior abdominal wall nerves. So again, subcostal nerve is not part of the lumbar plexus. You have iliohypogastric nerve, ilioinguinal nerve, genitofemoral nerve, and lateral femoral cutaneous nerve. So these are the nerves that are associated with the posterior side of the wall. Because he listed them on the slide thing, but I just put them right here. And again, this is another side note that we talked about, almost like near the objectives. Remember that we have 4 posterior abdominal muscles. Those are our psoas major and minor, the psoas major, psoas minor, iliacus, and our quadratus lumborum, right? So those are all going to be associated there, right? So which of the following supply the abdominal portion, basically, of the diaphragm? So abdominal, AB, yeah, abdominal portion, yeah. So A, B, C, or D. Give me a few seconds. Okay. So it is going to be, yes, it is going to be indeed B, right? So B, inferior phrenic arteries. The other 3, which you can use for your studies, are going to be supplying the thoracic portion, right? So the top portion of the diaphragm, right? So musculophrenic, pericardial phrenic arteries, and the superior phrenic arteries. And again, this image is used for your studies because if you remember the arterial pathways, you won't have to force yourself to remember these names, right? Because it's hard to remember like these long names if we really don't understand what they're doing, right? So if you understand the pathway, I feel like it's going to be much easier to remember like what arteries supply what. And like in regards to the thoracic surface or the abdominal surface. Okay, so for the kidneys, basically, the kidneys are always retroperitoneal. I know we're talking about like this peritoneal, like retroperitoneal, all this stuff basically before we even get to the peritoneum lecture, but this will make a lot more sense when we talk about this in the next like 2 lectures coming up, I think. Retroperitoneal, but just note that the kidneys, also known as the adrenal glands, which are just going to be just superior to that, are both going to be associated with being retroperitoneal, so behind the peritoneum, right? They lie in the paravertebral gutters, so I would for sure note that the paravertebral gutters are going to be from T11 to L3. So I would for sure remember that. So again, yeah. Let me see. Yeah, so I would definitely note that. I mean, my TA last year like really emphasized like knowing. I forgot why. Emphasized knowing the paravertebral gutters. I mean, she's the way that she said to memorize it. I mean, I didn't say it, but like she said, like you go out like at 11 p.m. and then you end up throwing up in the gutter at like 3 p.m. or 3 a.m. I mean, if that's what you wanted to remember it, I wasn't gonna put it on the slide, but if that helps you remember like T11 to L3, then that can help, right? So that's gonna be the paravertebral gutters. The kidneys are always gonna be retroperitoneal again. And then you have posterior surfaces walls, which we talked about already. So again, T11 to L3, I would for sure note that. And then here is your subcostal nerve, your iliohypogastric, and then your ilioinguinal nerve, right? So they're all running behind your kidneys, but they're obviously going to be anterior to the posterior wall muscles, which are like your quadratus lumborum, your psoas major, etc. So we're gonna talk about arteries like crazy, basically, when it comes into the next lectures coming up. Like arteries are just gonna be your best friend or your enemy, I guess. But we're gonna talk about a lot of branches off the celiac trunk, the SMA, the IMA, like in great detail in the next upcoming lectures. But here is just like a general overview of the unpaired arteries and then the paired arteries. So when he said unpaired arteries off the abdominal aorta, so when you cross that like median arcuate ligament, right, your aortic hiatus, what's going to happen is that you have these arteries. Now it's called abdominal aorta, right? The unpaired arteries are just the arteries that come off like by itself without like an artery on the other side. Like for example, like the renal arteries are paired on each side. The gonadal arteries are paired on each side, right? But the celiac trunk, the SMA, which is the superior mesenteric artery, the inferior mesenteric artery, and the median sacral artery are all going to be unpaired. They're just coming straight down the abdominal wall, and they're going to eventually give off their own branches of other arteries, right? So those would be the unpaired. I would also note what he said in the lecture, basically, is that on the right side, basically, your IVC, basically. Okay, so if you're looking at a cadaver image, right? So, and you're trying to like decipher where you are, basically, if you see the IVC and the aorta, you always know that the IVC is going to be on the right side. The abdominal aorta is always going to be on the left side. And that's number one. That's important to know. Number two is that the gonadal vein is always going to be on the right side, draining into the IVC, basically. So you see this right gonadal vein, basically, this right here? It's going to be draining into the inferior vena cava. On the left side, though, the gonadal vein is going to drain into the left renal vein, right? So I wrote that right here. So the gonadal vein draining into the left renal vein. So those are two things that are different. It's kind of odd why it does that. But the left, basically, you got to know that the left gonadal vein drains into the left renal vein, and then the right gonadal vein is going to drain into the IVC in the inferior vena cava, right? And again, on one more thing I would note on this slide I put here is that your superior mesenteric is on top of your renal vein, and then your renal vein is on top of your abdominal aorta, right? So obviously like superficial to deep, right? So I would note that in its order in regards to what is located right here. So I put that right here, don't worry. Left renal vein, which is going to be superior to the aorta and inferior to the SMA, right? Okay, so typically the right kidney is lower. The reason why the right kidney is lower is because of how large the liver is, right? So the liver takes up a very large space, and that's just the reason why the right kidney is usually lower than the left kidney. Nothing too important here other than the fact that the nerves that are going to be wrapping behind the kidneys, but anterior, like in front, basically anterior to the psoas major and like the quadratus lumborum, is going to be your subcostal, iliohypogastric, and your ilioinguinal nerves. Those are all going to be running right there, just posterior to the kidneys, right? Okay, so again, here we are. Our subcostal, our iliohypogastric, and our ilioinguinal are all going to run posterior to the kidneys, but anterior to the posterior abdominal wall muscles, right? And of course, he said that that's very important clinically, obviously, because you don't want to puncture these nerves, right? Okay. These three nerves run posterior to the kidneys and anterior to the psoas major and quadratus lumborum muscles, right? So again, your subcostal nerve, your iliohypogastric nerve, and your ilioinguinal nerve are all, I mean, he repeated this a lot, so I feel like it's pretty high yielding. Your subcostal nerve, your iliohypogastric nerve, and your ilioinguinal nerve are all going to run posterior to the kidneys, but anterior to the psoas major and quadratus lumborum. Nothing too important here. We're going to talk so much about peritoneal structures in the next few lectures. Cross section, not too important. So basically, you have your perirenal fat, basically, and your pararenal fat. So, I mean, I was trying to find a good way to memorize this for y'all, but like, I mean, the best way I could think about is that perirenal fat, basically, the I in perirenal, basically, is inside the renal fascia. So maybe that'll help you remember that it's going to be associated with being on top of the kidneys, right? So basically, you have your kidneys, then you have your perirenal fascia, then you have your renal fascia, then you have your pararenal fat. That's what I meant, perirenal fat, right? So again, kidneys, perirenal fat, renal fascia, and then you're going to have your pararenal fat, right? So just so you don't get confused, maybe this will help. Perirenal fat, so the I is going to be inside the renal fascia, so it's going to be on the kidney, right? And then pararenal fat will be outside the renal fascia. Okay, so which of the following is the correct order of the unpaired arteries off the abdominal aorta from superior to inferior, right? So I know this is a tough one, but this will help you with your studies too. So SMA, IMA, celiac trunk, median sacral. So is it going to be A, B, C, or D? So superior, going from the highest portion all the way to the lowest portion. And obviously these are the unpaired arteries. You still have like paired arteries coming off, but I'm just talking in relation to the unpaired arteries. I'll give you one more second. Okay, so yes, it is going to be C, right? So celiac trunk, SMA, IMA, and then median sacral artery. That median sacral artery basically just comes off when the abdominal aorta makes that bifurcation, basically, or makes that bifurcation into the common iliacs, basically. You're going to have that median sacral artery that's going to be coming down right in between that, basically. So that's going to be your median sacral artery. It's the most inferior portion. Okay, this is for your studies, so use this to study. I'm not going to go over this too much, but these are going to be your paired vessels off the abdominal aorta. I mean, it makes sense because they're called like inferior phrenic arteries, like suprarenal arteries, like it's plural, right? Usually, while the unpaired vessels are not plural, right? So celiac trunk, SMA, IMA, and median sacral artery. So, but I just listed them here just to help you out. And these would be going from superior to inferior in relation to their own category, prospectively, right? The kidney, we'll talk about. I think I put a picture on this for capsule. The capsule is just going to be the outside of the kidney. We'll talk about the cortex, the medulla, this region right here, which is called the papilla. Then you're going to minor and major calyxes, and then the pelvis, the renal pelvis, and the ureter. Okay, so I think on the next slide, yeah. So basically, I put this image in here just for you to study, just to help you like understand the anatomy of it. But the capsule, basically, like we showed in the last slide, is just that portion that's surrounding the kidney, right? So that's going to be that. The cortex is just going to be this portion right here. Then we have our renal medulla, or renal pyramid, I would say, our renal pyramid. Then you have the renal papilla, minor and major calyx, so minor and major calyx, and then renal pelvis. So basically when the renal papilla is there because basically when your kidneys are filtering like all this fluid, basically, eventually the urine is going to go from the cortex, basically, down the renal medulla and out the renal papilla, right? So basically, the urine's going to come out the renal papilla and into those minor calyxes, right? The minor calyxes then fuse and make the major calyxes, and then make the renal pelvis, and then the urine goes out the ureter, right? So that's what happened. That's the order basically of how that goes. This I just highlighted what he said, but just typically the renal artery gives off 5 branches that supply the 5 lobes, right? That's about it basically. Okay, so kidneys. So here's the image of it. They look like beans. So here's the kidney, like it's like a kidney bean. So here's your kidney. The suprarenal gland is going to be the portion that's on top of it. So it's going to be like right here and like right here respectively. So those are going to be the kidneys. Okay. So for renal vessels, right? So the note that I would give for you in order to like help you visualize where you are in a cadaveric image is that the left renal vein is typically longer than the right renal vein, right? So because it has to come all the way across the abdominal aorta in order to supply the left kidney, right? Because we know the IVC, right, is going to be on the right side and you have your aorta on the left side, right? So this is going to be longer, right? Your left renal vein is going to be longer. So once you point out that left renal vein, everything else will come into play, right? So if we know that this is the left renal vein, this has to be the right renal vein, right? Because it's going into the kidneys. Then we have our abdominal aorta, which is going to be this portion right here, giving off our renal arteries right here. This is gonna be our renal arteries. So I just split this up into like 2 slides, I think. So he talked about the kidney renal sinus, which is just the portion inside of the kidney that has all the vessels, basically. So this is the renal sinus, right? Again, this is just a cut of it. I mean, it would be pretty easy to identify because you can see this is the kidney, but this is all the structures going into it, so it has to be the renal sinus, right? So I just put like a little image there. You don't have to know everything else, but just note the renal sinus. And then you have your kidney structures. Again, the cortex is going to be on the outside portion. Then you have your medulla, right? Then you have your medulla. Then you're draining into your like minor calyx, which is roughly around here, and then into your major calyxes, right? So here are your calyxes, right there, and this is your papilla, right? So remember where I said like this is your renal papilla right here. This portion right here, it's draining urine into the minor calyx, which then goes into the major calyx. That's your papilla right there. Okay. The ureter is going to cross over the external iliac artery and vein, right? So remember, your ureter is going to cross over the external iliac artery and vein, but it's going to cross under the uterine artery in females, but it's going to cross under the vas deferens in males, right? So again, the ureter is going to cross under the uterine artery in females, and it's going to cross under the vas deferens in males, right? So that's when we talk about our water under the bridge. So water under the bridge. So basically, what he said when he said that quote, basically, or that thing to remember, is that water is going to be the ureter, right? So obviously it's like urine, but just associated with water. So that's going to be water. The bridge is going to be your uterine artery in females or your vas deferens in males, right? So water, which would be a ureter, is under the bridge, which would be uterine artery or vas deferens. So you can see a uterine artery here, and you see your vas deferens, also known as your ductus deferens right here. All right, so hopefully that image should help there. And again, here is your water, which is your ureter, and then your bridge is going to be your uterine artery, and the bridge in males will be the vas deferens. So again, here's the ureter. Again, vas deferens over the ureter in males, but the uterine artery over the ureter in females. So again, this is your ureter, and this is going to be your vas deferens, right? This is the deep inguinal ring because your vas deferens is coming out your deep inguinal ring, eventually to go into like your, obviously into your, the prostate gland, your ejaculatory duct, etc. It goes through all that, right? So that's going to be the vas deferens.
Quick question, Justin. So you've got the uterine artery, then the ureter, then the external iliac, and what else? Like what else is underneath the ureter?
So above the ureter in females is the uterine artery.
Okay.
Above the ureter in males is going to be the vas deferens.
Yeah, and then you have the external iliac below that.
Below.
And what was the other thing that's with the external iliac below the ureter?
That was it, I think.
Oh, really? Okay, thank you.
Yeah. The vein, but yeah, external iliac artery and vein. Okay. He's not going to test on this, so I'm just going to skip this slide. You don't need to worry about this. He's not going to test on this. You'll get this a lot more in actually pharm as well as some neuro. Okay. What is the structure indicated by the arrow, right? So which one is this? Is the right venal vein, artery, etc. We're almost done here. Okay, I'll give you one more second. So yes, it is going to be the left renal vein, right? So left renal vein is typically going to be longer than the right renal vein, right? So which would be on this side. It's much shorter. Right, so very good job on that. It's going to be the left renal vein. Kidney stones. So I would just note where the referred pain is going to be. So I highlighted what I believe was going to be the highest of yields. So loin to groin basically is going to be the sign basically of kidney stones. So from the loin to the groin basically, and often patients feel their bowels are involved as well. That's just because like the visceral afferents and the colon are going to be from the same spinal level. But again, I would just note these that I highlighted here. Again, it's kidney stones. Basically, it's going to be like these calculi stones, basically going through the ureter and could possibly damage or obstruct the ureter. Right? Obviously, that'd be extremely bad. But yes, this is kidney stones. Okay, so adrenal is suprarenal glands. So again, remember your kidneys and your adrenal glands are going to be retroperitoneal, right? So they're going to be behind the peritoneum, and then you have your right adrenal and your left adrenal. But if we know our like anatomy of the abdomen, right? So we should be able to put together that the right adrenal is behind the bare area of the liver, right? Because the liver is more so associated with the right side. So the right adrenal is behind the bare area of the liver. We'll talk about what that is. We'll talk about what that is in the next upcoming lectures. And then we also have the left adrenal, which faces into the omental bursa, which we'll also talk about that later on. But that's just going to be a bursa that's going to be surrounding the abdominal cavity. Okay, so I would note that here. Nothing to talk about here. Again, this is for your studies, but again, these are going to be your paired vessels off the abdominal aorta, which I listed right here. And these are going to be your unpaired vessels, which I put right there. Remember, they're going from superior to inferior, so I listed them in that order. Okay, so I would not note anything. The only thing I would note basically is the cortex has no innervation, and there is no parasympathetic innervation in general to the adrenal glands, and that makes sense, right? Because the adrenal glands are for flight and fight response, basically. So it's only going to be sympathetic, right? But the sympathetic innervation is only going to be to the medulla of the kidneys, right? Because the medulla of the kidneys is what produces like your epinephrine and your norepinephrine, right? Which we'll talk about later on. But then your cortex of your kidneys produces like aldosterone, cortisol, like all these other like hormones and stuff like that are not associated with sympathetic innervation, and they're regulated by releasing factors coming from the thyroid, coming from the pituitary gland. But what's super important to know is that the cortex has no innervation. The reason why it does not have innervation is because those hormones are regulated by releasing factors. The medulla has sympathetic innervation because you have norepinephrine and epinephrine being produced there, right? Norepinephrine and epinephrine produced in the medulla, right? And then there's no parasympathetic innervation at all in the entire adrenal gland, all right? So I would definitely for sure note that. Again, this is your right adrenal gland. The reason why I know that is because look how short this renal vein is, and then you see your left adrenal gland, and look how long this renal vein is, right? So that's going to be those. Again, cortex, medulla. So I would definitely note, like he can point at this and be like, what's produced here, because he said it in class. So I would note that, like he can cover this obviously and be like, what's produced here. First, you have to know that's the medulla, and second, you have to know that epinephrine and norepinephrine are produced in the medulla. So. And then it gets sympathetic innervation. No innervation here in the cortex. Again, these are for your studies. Paired and unpaired. Again, I just copied and pasted it. We talked about this already. Remember that the left side, the gonadal vein is going to drain into the renal vein, but on the right side, it dumps into the IVC. This is just another note on that. And again, here's another helpful tip that we talked about. Okay, nothing to talk about here. So celiac trunk and pit. So he said not to worry about these bottom right ones. Not yet, obviously, because these are going to be the branches coming off the celiac trunk, which we'll talk about in the next lecture, the next upcoming lectures. But I would note the abdominal aorta, the bifurcation, and then the celiac trunk, right? So this is going to be that celiac trunk. So I would note these three. Oh, yeah. So I was looking at the celiac trunk and I swore it looked like something in SpongeBob. So I was looking it up online. I was like, I know this looks like this like plant. So I found it, and then that's what it looks like. But obviously that's only what the celiac trunk looks like when you cut its branches off, right? So they cut the branches of the celiac trunk, and it just looks like the top of this plant for me. So I just put it there. I mean, hopefully that'll help you remember that. So that's going to be the celiac trunk, and then unpaired branches off the abdominal aorta. So here's our celiac trunk right here. SMA is just inferior to that, and then these are going to be our renal arteries, right? So renal arteries are going to be just bifurcating to the side. The reason why I couldn't like put these on like an associated pictures or associated with slides is because we didn't talk too much about these individually, so I just left them here. But I'm giving hopefully I'm giving you some tips to help you in regards to understanding where the relation of these are. So, and then this is going to be the IMA. We'll talk a lot about these more, but specifically the median sacral artery, it's going to go to the sacrum, right? But it happens at the bifurcation of the aorta, right? So which is going to be right here. Here's the abdominal aorta bifurcating into the common iliacs, and here's your median sacral artery, just going straight down to your sacrum. Right. Again, renal arteries, celiac trunk, SMA, right? So celiac trunk, SMA, renal arteries, testicular arteries right here, and then lumbar arteries because they're just going to the lumbar region. Yeah, same thing here. Yeah, so common iliac, we know this. We already know the flow of this, right? Because we know the abdominal aorta branching, common iliac, and then internal and external iliac, right? So the one that's going to be associated with like I would say like lateral side, I guess, would be the external iliac, and then you have this one going towards the pelvis, which is your internal iliac, right? And then inferior epigastric artery. So again, does anybody remember what fold the inferior epigastric artery was on?
Lateral?
Yeah, so it's on the lateral fold, right? So that's going to be the inferior epigastric artery. I find it really cool because what the inferior epigastric artery attaches to the external iliac artery, right, which is right here because then it turns into femoral. And then what it does is that the inferior epigastric artery actually is going to basically anastomoses with the superior epigastric as it goes up, and eventually it goes back to the internal thoracic. So it's really weird like how it all connects, that like the internal thoracic from up here eventually goes all the way down to the inferior epigastric and connects to the external iliac. You don't have to know that, but I just thought it was really interesting as to how the inferior epigastric gets all the way over here to the external iliac. So the deep circumflex iliac artery, the way for you to remember that is that it just basically just wraps around the iliac, right? It says what it does basically. So around the iliac, and this is this deep circumflex iliac artery just wrapping around the pelvis, right? And here's our femoral artery because it passed the inguinal ligament. And this is just the same thing, but in regards to the veins, right? Same pattern. And then we talked about IVC. We talked about the renal veins, the left one typically being longer, and your left testicular vein. You have to know that this is your left testicular vein for sure, because you know it goes into the left renal vein. The right testicular vein goes where? Anybody know? The right testicular vein?
IVC?
Yeah, so IVC, yeah, right testicular vein into the IVC, left testicular vein into the renal vein. So that's our left testicular vein right there. And then, yep, oh yeah, and then the superior epigastric and inferior epigastric. So I told you basically superior and inferior epigastric vessels come down to your external iliacs, but it's going to go up and anastomoses with your superior epigastric vessels, and eventually it's going to find its way all the way back up into the internal thoracic artery, which will branch off the subclavian artery, right? So it's kind of like coming straight down. Really interesting, actually. And then we already talked about these, and I put them in their orders. So the thing I would just know here is the kidneys and testes drain into the para-aortic lymph nodes and other lymph nodes in that region, right? Because like we said, that the testes are going to drop down from roughly the kidneys region, and that's why it's getting all of its supply from the, I would say, superior abdominal region, right? To know here, basically, you have your chyli cisternae. Now, I would just put the highest of your chyli cisternae going into your thoracic duct, which then goes into your left subclavian vein. Right, so basically that's going to be the flow of lymph, right? So lymph is going to go from your chyli cisternae to your thoracic duct into your left subclavian vein. So yes, your lymph is eventually going to mix with your venous blood, right? Lymph and like venous, like in blood, is not the same thing. So lymph is then going to go in and drop into the venous blood via the left subclavian vein, right? So remember, it's the left subclavian vein for the thoracic duct. We'll talk about this a lot more, but the portal venous system we know is going to be between the liver and the spleen, basically, but it's going to be a lot of digestive organs. I mean, it's not just the spleen, but the spleen, digestive organs are all going to connect to the liver via the portal vein, which we'll talk about a lot more. So I won't hone on that too much. Okay, and then lastly, these are just the three main sites of anastomoses. What he's saying here is that you have a portal and a caval anastomoses. What that means is that you have your portal vein, right, which connects to your liver, and your caval just means your IVC. So we know your IVC gives like a lot of branches, right? And we know your portal vein actually as well gives a lot of branches. These branches from your portal vein and branches from your IVC are going to anastomoses with each other, right? And that's what they say, the three main sites of anastomoses, that's what they're talking about. The anastomoses between the branches of the portal vein and the branches of the IVC. That's what he's talking about when he says branches or three main sites of anastomoses. So for example, in the esophageal veins, you're going to have anastomoses from your IVC as well as your portal vein, right? Same with the paraumbilical veins, and same thing with the veins of the anal canals, right? So these first two are going to be associated with alcohol abuse and cirrhosis. These not so. These veins of anal canals are more so associated with hemorrhoids. So hemorrhoids are going to be more associated with these, while the esophageal veins and paraumbilical veins are more so associated with alcohol abuse and cirrhosis. And then again, this is like, do not memorize this picture. It's just for reference. It's just to show you how like the esophageal vein, which is going to be like anastomosing with portion off the inferior vena cava, same thing with the paraumbilical, and same thing with the veins of the anal canals. And this is just a summary. And that's it. Oh, okay, yeah, so not too bad, not too over time. Okay, not too over time. Any questions? So this one wasn't too long, so that's good. Any questions?
Question?
Yeah.
Anastomoses means like they just like combine.
Yep.
Okay. Thank you.
Yep.
Hey, Justin, what did you say that the veins of the anal canal did?
The veins of the anal canals, anastomoses with the IVC as well. Well, depending on the branches, but those are associated with hemorrhoids if you have problems there.
Hemorrhoids, got it. Thank you.
Yep. All right. Any other questions before I let you all go?
Yeah, Justin, he mentioned the three major unpaired arteries coming off the aorta, so celiac, the superior mesenteric, and the inferior. And I noticed you mentioned the median sacral. Is he going to want us to know more about the median sacral, or just kind of just know that it's there?
Yeah, I would just know that it's there.
Okay, cool. Because I totally forgot about that, man. So thanks.
Yeah, I know. I forgot about it too, and I was like, let me just put this here just in case.
Yeah, appreciate it. Thank you.
Gotcha. Oh yeah, I'll see any of you at the 2 p.m. if you go in person as well. So I'll be on campus at 2 p.m. today. Got you. Yeah, for sure. Let me know if you all need anything. But yeah, if you have any questions, I'm here for a little bit. All right, yep. So I seem like there's no questions. If not, take it easy, y'all. Have a great weekend. And if I'll see you at the 2 p.m., I'll see you at the 2 p.m. But if anything, have a great weekend.